Assalamu alaikum and welcome to this session. My name is Dr. Fahim Shahzad. I am working as a lecturer at the Department of Allied Health Sciences, which is Lahore. And I have the honor of to conduct this session as a moderator. So to start formally, we would like to start this session from Tilawat Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم.
Jazakallah. Now I would like to call upon General Secretary PSI, Professor Dr. Umar, to come up on the stage and have some few words. Please.
Bismillahirrahmanirrahim. Distinguished guests, respected seniors, colleagues, conference delegates, ladies and gentlemen, Assalamu alaikum. As General Secretary of PSI, it is my privilege to welcome you all at the commencement of the scientific sessions of PSI. It is heartening to see that PSI has come a long way since its inception and has steadily and slowly broken new ground, crossing ever new milestones in its onward journey. This is indeed due to the continuous patronage extended by the seniors who pioneered the establishment of this society and have since continued to guide its journey and have graced the present session by their presence. This was also possible in no small part by the significant efforts put in by the PSI Scientific Committee, especially Dr. Sabiha and Lieutenant Colonel Tipu as the chair and co-chair, who made sure that the scientific content of the PSI sessions is commensurate with the best possible standards. Our special thanks goes out to them. Lastly, the participation of a large number of presenters as well as delegates in the free paper session is a welcome step in the right direction and is a good omen for the society for the times to come. I will now request Dr. Fahim to continue with the proceedings for today's session. Thank you very much.
Thank you so much, Dr. Umar, General Secretary PSI. Now I would like to call upon Chairperson Scientific Committee, Professor Dr. Sabiha Anis, to come up and have welcome address. Thank you.
Assalamualaikum everybody. So as a chairperson of this PSI Scientific Committee for 2023, I extend my heartiest welcome to you all in this conference. And first and foremost, I actually want to show my gratitude to Colonel Dawood, who actually put in his trust in me and made me the chairperson of the scientific committee. So as Colonel Umar said, it is a very amazing scientific committee, and really they have worked very hard, and we had several sessions of meetings with the PAP scientific committee also and amongst us, and we have tried to put our efforts to for these 2 days PSI session to be very interesting for you and knowledgeable for you. So the committee included me, Colonel Dawood, who is the president of the PSI, Colonel Dr. Hamid Nawasi, who is the co-chairperson of this committee, Colonel Dr. Umair, who is the General Secretary of the PSI, Dr. Wajia, who is the Finance Secretary of the PSI, then Dr. Sabah Sarfraz, Dr. Mehjabeen, Dr. Louisa, Dr. Sarah Abdul Qadir, Dr. Abdul Qadir, and Dr. Fahim. And these two amazing ladies, they have done a very good job of organizing two very successful workshops yesterday and day before yesterday. Dr. Benjamin organized a workshop on the flow cytometer at PKY, and Dr. Louisa Tahir organized a workshop on the IFA at UHS. So a big for them. So these are our esteemed invited speakers, including Professor Rabia Hussain and Dr. Senisa Sevik. It is really very sad that they could not be present, these two speakers with us in person, but they have sent their recorded talks, and we will play it during their session. Then we have very esteemed speaker, Dr. Masroor Babar, then Dr. Adil Manzoor, Dr. Naki Zafar, Dr. Sheba Mirza, Dr. Colonel Dr. Hamid Namastipur, Dr. Khawar Abbas, and Dr. Najiha Talab. Then we have Dr. Dawood Ahmed, Dr. Fahim Shehzad, Dr. Sabah Sarfraz, and Dr. Wajiha Musharraf. So the chairs of different sessions include our Abdulaziz Professor Dr. Tahir Aziz Ahmed, Professor Ghazala, Professor Nadeem, Dr. Samia, myself, Colonel Dawood, Dr. Khawar Abbas, Dr. Hamid Namastipur, and Colonel Dr. Umair Riaz. We have around 14 free oral papers and 12 poster presentations. These are our judges during the grading of all the oral abstracts, and 2 of them are going to grade the posters as well. The moderators, the captain of the ship, the captain of the own sessions, they are going to now take over all the sessions and work along with. So I hope that you will enjoy these 2 days of excitement, full of knowledge. We'll share and gain the knowledge amongst us. Thank you very much. Have a great day.
Now it is the time to introduce chair and co-chair for this session. Chair for this session is Professor Dr. Samia Anis. Dr. Samia Anis is working as a consultant immunologist and section head at Indus Hospital and Health Network, Karachi, since 2018. She is a fellow of College of Physicians and Surgeons, Pakistan, and an associate member of Royal College of Pathologists. She is also a founding member of Pakistan Society for Immunology. Arranging workshops and seminars in immunology is her passion. Her main areas of interest are primary immunodeficiency and allergies. She has authored several articles and a book chapter, and is reviewer or editorial board member for several peer-reviewed national and international journals. So please welcome Professor Dr. Samia Anis. Madam, please take your seat. Now I would like to introduce co-chair of this session, Lieutenant Colonel Dr. Umair. Dr. Umair Riaz, a seasoned professional, completed his FCPS training at AFIP and has been a pivotal figure in activities of PSI since its establishment. Presently, he holds the esteemed position of General Secretary at PSI and serves as the head of the Department of Immunology at AFIP, showcasing his dedication and leadership in the field of immunology. Please welcome Lieutenant Colonel Dr. Umair. Sir, please take your seat. Now we will proceed to start scientific sessions, and I hand over it to chair and co-chair.
We'll start the session now, as we are getting late. So as I told you that my introduction, that Dr. Sinisa Sevik will not be present in person. He may not be available on Zoom as well, although we have shared the Zoom link with him. So I'm going to introduce and then we will get started here. Dr. Sinisa Sevik is an accomplished immunologist specializing in primary immunodeficiencies and allergy. With extensive experience and robust research portfolio, he currently leads the Department of Clinical Immunology and Allergy by providing dedicated patient care. His research primarily focuses on unraveling the molecular mechanism behind primary immunodeficiencies and systemic autoimmune disorders, utilizing cutting-edge genetic techniques and functional assays. Dr. Sevik is a respected group leader in clinical and translational immunology, playing a pivotal role in enhancing our understanding of immunological disorders. He holds various professional memberships and has led numerous studies aimed at improving diagnostics and treatments in clinical immunology. Can you please start this talk?
First of all, I would like to thank the organizers for inviting me to speak at the meeting. I'm sorry I can't be there in person, but I hope that this video will serve the same purpose. The aim of my presentation was to give you a current update on current aspects and prospects of primary immune deficiencies. And for this purpose, I thought that maybe the most relevant topic to cover would be what progress has been made in terms of diagnosis of primary immune deficiencies. And in particular, I wanted to talk a little bit about neonatal screening, what experience of this has been so far, and what the problems may be, and advantages of introducing this widely. Also wanted to talk to you about the value of genetic testing in primary immune deficiencies and some of the problems and advantages again of using this modality to diagnose patients with these disorders. And lastly, I will touch upon some of the latest progress, particularly in terms of use of artificial intelligence in diagnosis of primary immune deficiency. So when we think about screening tests in general, there are a number of considerations that we need to be aware of before introducing these tests for wider use. Firstly, the health, it is important that the condition we want to screen for is judged to be important due to its frequency or severity, that we know the natural history of the condition, its prevalence, and the disease is understood in that respect, that we have a relatively simple, safe, and validated screening test that should be widely available, and that such tests should have low possibility of false positive results. It's also important that any screening test should allow early detection of the disease, which will improve the outcome, and that screening test should be applicable to the whole population. The test should be of acceptable cost, considering what potential benefits of screening are, and that there should be a follow-up test to help us to distinguish between the true false positives and true positives that we have identified in screening. And when we think about primary immune deficiencies, disorders that generally would fit most of these requirements are those that cause severe combined immune deficiency. Severe combined immune deficiency is key. It's a health emergency. If not diagnosed promptly, can lead to really poor outcomes. We now have good treatment options for patients that have these disorders, including bone marrow transplants that can be provided early in the disease course. So the way to screen for SCID is using T-cell receptor excision circles, which is one of the validated screening tools that have been tested over the years and found to be effective in terms of identifying patients with SCID. The test identifies patients who have low T-cell numbers, which by and large are patients with SCID, and works on the principle that detects the circular fragments of the DNA, which are the tracks generated in enzymes during the BDJ recombination reproduction T cells. These tracks are largely produced by naive T cells, which again is relevant to SCID because these are the cells, T cells that we are largely interested in understanding of their data. We can readily assay DNA extracted from the blood spots, which is obtained for newborn screening for other causes. And there are, as I say, studies which have shown previously that absent low tracks in newborns can readily identify pretty much most cases of typical SCID. There were some, early suggestions how we should approach screening for SCID using tracks. This is one of those examples that has been proposed a number of years ago. And again, it's using the advantage of methodology that's already in place in many countries where battery cards are used to collect dried blood spots. Blood from these cards can be used to extract nucleic acids and then test for presence of traps. If you have normal levels of traps, that would imply normal levels of T cells, and therefore no further action is needed. If you have low levels of traps and having abnormal test as a result, this would indicate low levels of T cells and possibly suggest that a screened infant has potentially skin. If we exclude other causes for low T cells and tracks such as prematurity and sepsis, then you would want to go on and confirm that indeed those low levels are indeed suggestive of skin, and you would need to include second-tier testing, which may include lymphocyte analysis by FACS, lymphocyte phenotyping, and so on. And then you would go on to, of course, work up the case and potentially treat the patient for severe primary immune deficiency. But what's been experienced of all of this so far? Obviously we have this relatively validated test that's now being used widely, but what has been the knowledge and experience that we have gained so far? The most experience using TRACS for SCID screening has been in the United States. This is where the majority of the pilot studies were done between 2008 and 2010. In 2019, whole the United States has introduced TRACS screening for SCID. Interestingly, from some of the earlier studies, what's been shown very quickly is that incidence of SCID is actually probably higher than we previously thought. This is probably not a surprise, given that TRACS screening has helped to identify cases which were previously missed. There was also a suggestion that better survival is already seen in some of these forms of SCID. So, for example, ADA deficiency type SCID is a suggestion that survival may increase from 70 to 92% as a result of screening because of early intervention. Screening has now been adopted by several additional countries with their own experience now being reported. But there are some potential problems with using TRACS to screen for SCID, which is that in addition to SCID, TRACS will pick up some other combined immune deficiencies which may have low T cell numbers but not necessarily be SCID. So, for example, the Joe syndrome, the 29 and so on. The low TRAC numbers may be seen in other situations, so for example in preterm infants, and other non-immunological disorders which may include cardiac and gastrointestinal, which are not necessarily included in SCID. So there are false positive tests that need to be borne in mind. At the same time, with false positive tests which can cause parental anxiety and additional screening, there are false negative examples, although these are far fewer. For example, hypomorphic variants in certain SCID genes such as IL-2 receptor gamma chain, SCID or ADA deficiency, RAC1, RAC2, leaky variants of SCID may be missed in this case. But there are other issues such as administration and facilities to have confirmation tests. Then the most simple confirmation test in many cases could be just doing full blood count, which would confirm the enumeration of the lymphocytes. However, in most cases, what is really required is to perform proper lymphocyte phenotyping to understand the effects on lymphopenia on different lymphocyte subsets and help that diagnosis. There are variable reporting strategies across regional variations, and as shown in the figure on the bottom of the slide, with the introduction of TRACS screening across different countries, what's been realized that the threshold for potentially investigating SCID patients varies, and that may be population dependent. For each country, it's necessary really to do some validation studies to establish the threshold for further investigations. Another important point to make, although as I say, the drug screening will pick up some other immunodeficiencies due to low T cell numbers, some other very important primary immunodeficiencies for which early detection will be valuable are not picked up by drugs. We need other ways in which we can make a diagnosis of these conditions early on to improve their outcomes. And to illustrate this problem, this slide just shows where we got to now in terms of number of different inborn areas of immunity, and as the most recent update, we are now dealing just with under 500 different monogenic disorders that have been described. So there is a great need to be able to readily diagnose many of these conditions, given that their early diagnosis will help to improve outcomes in at least selected cases. But doing that on a scale is difficult, given, as I said, the number of different conditions that could potentially be investigated. Therefore, wider use of genetic testing has been proposed as a way to help with this problem, and genetic testing has been supported by a variety of clinical immunology societies across the world as a way of improving diagnostic pickup and improving diagnosis overall in patients with suspected primary immunodeficiencies. And there are certain advantages, of course, of using genetic testing early, because you can establish diagnosis earlier, and by establishing diagnosis earlier, you can already implement adequate treatments. You can inform the patients and the family about potential prognosis and implications and other valuable information that the family may want to have, including family screening. But there are many remaining challenges. Firstly, there is access to genetic testing for PID, which is not universal, but that's improving. The cost of the test is still prohibitively high for certain areas of the world, and growing increasingly, it is the interpretation of these tests that is a problematic issue, which I will come to address in the later stages of this presentation. So what modalities can we use to do genetic testing in primary immunodeficiency? And this table here shows different approaches with their relative advantages and disadvantages. And briefly, I'll just mention that single candidate gene sequencing using, for example, low-cost sample sequencing is largely abandoned because of the number of different monogenic disorders that we tend to look for in each individual patient, given that there are greater increasing number of genetic disorders that have clinical features. It's very hard on clinical grounds alone to be sure 100% that this is exactly the condition you want to be testing for. There are, of course, exceptions where you may have other investigations that may suggest that it's a particular disorder that you want to be looking for. So recently, for example, in my center, we identified CD19 deficiency by doing FACS lymphocyte phenotyping, and we confirmed that by single gene sequencing, but that's very rare. The testing has really moved towards using novel next generation sequencing, either by using targeted panels or using next generation sequencing platforms such as whole exome sequencing or whole genome sequencing. And each one of these approaches has its relative advantages and disadvantages. Targeted genome panels have advantage in that, of course, you can test for more than multiple candidate genes at the same time. These are again pre-selected genes, so the interpretation may be easier because you have a kind of limited number of genes that you want to be looking at. And also, the targeted panels allow you for more detailed analysis of those genetic regions. Therefore, you can look for somatic mosaicism, which is relevant for some of the primary immune deficiencies, and it's not always necessarily picked up by other techniques. There are various methodologies by which you can do targeted genome panels. You can use whole exome sequencing or whole genome sequencing, where you limit your not only to the candidate genes that you want to analyze, and therefore avoiding the need to deal with findings that are difficult to interpret or unexpected. The next level of methodology that you can use for this purpose obviously is whole exome sequencing, which is mainly looking for coding regions of the genes. And again, this allows you to look for much wider number of genes, and you can look for the whole genome that is currently known. Now, this technique also allows you to look for potentially novel genetic causes, but interpretation is a problem. And whole genome sequencing, in addition to whole exome sequencing, is again the next level, whereby you can not just look for the coding regions of the gene, but also the regulatory components of the genome, which may contain relevant variants. And more importantly, whole genome sequencing is also much better in terms of picking up structural variants that might be missed by any other technique. But as I say, it's interpretation of these findings that can be quite challenging. And our understanding and approach how to do that is improving all the time. And there are different levels of evidence that one needs to be able to interpret the genetic findings. And this is really applicable to any disease as well as primary immune deficiency. So there are now many healthy population databases which have genetic data on population levels. And if you do have a genetic finding, you can check your genetic finding against these databases. And if your variant of interest is not found in these databases, that gives it the potential to be pathogenic, because obviously it's not found in otherwise healthy population. When you also interpreting the findings, you're thinking about the functional consequence of such genetic change. Now, the gene of interest needs to make biological sense in terms of what you're looking for, but also the change in the genome may be in particular part of the protein which is highly conserved throughout the evolution, again suggesting that this is likely to be an important part of the protein that's being mutated. And again, it's important to think about the mode of inheritance that you're looking for in particular cases. So, for example, if you're looking for consanguineous families or biallelic inheritance, of course, you're looking for two pathogenic variants in the same gene, and that's needed really to make a diagnosis. So there are many computational now methodologies which can be used to predict potentially pathological effect of some of these genetic findings, and you need to really incorporate all of these different levels of evidence to really then decide whether or not the finding you have is definitely pathogenic or one of these variants of unknown significance, which you can only really properly test by doing some of the functional analysis. And using this case from my clinical practice, I just want to illustrate some of these problems that are seen in everyday clinical practice. So we had this case of a 7-year-old girl who came from non-consanguineous family, no prior family history of immune deficiency, but she presented with 12 months history of recurrent chest infections. She had previous history of nostril contagiosum, which was quite prolonged, but she was otherwise well and completed all her primary immunizations without any complications. So when she was seen in immunology clinic, we conducted some of the initial investigations, and then picked up quite significant lymphopenia with total lymphocyte count 0.3, 10 to 9 per liter, and she also had reduced activation on CD3, but normal PHA functional responses on the T cell activation. And we then performed our targeted panel that we had at the time, which really consisted of only 40 odd genes that were thought to be associated with various types of immune deficiency. And what this gene panel picked up was a heterozygous missense variant in a gene that codes for adenosine deaminase, which is, of course, linked with ADA SCID. In this case, we had only one hit, whilst usually in ADA SCID, you're looking for either homozygous or compound heterozygous mutations that would lead to complete absence of enzyme capacity. The missense mutation that we had picked up also was very rare. It wasn't previously described in any of the population databases, and it was in a very highly conserved part of the protein, all suggesting that this indeed was likely to be a pathogenic variant. Nevertheless, this was still only one variant. We still needed the second variant on the genetic point of view to make a diagnosis. But what was quite fortuitous in this case that other than genetic test, what's also helpful in this case is that you can do a biochemical test of enzyme function. And in this case, when we tested the patient sample, that showed complete lack of ADA enzyme activity, which then suggests that indeed what we were dealing here with was truly ADA deficiency leading to primary immunodeficiency problem. We then wanted really to dig deeper and try and identify the second variant, which wasn't evident from the initial test. We used a combination of RNA sequencing and whole exome sequencing using proband or the case material, plus then screening the mother and the father. And basically, having conducted these tests, we found that the child, in the child's case, there was only one allele that was transcribed. This is the allele that contained the novel variant, but in mother's case, we had transcription of two alleles which were not picked up previously in the child. And when we done whole exome sequencing, we identified that the second allele contained large deletion component which was not picked up by our panel testing. We were able to confirm that indeed the second allele did contain a significant deletion which was leading to this allele not being transcribed at all. And in essence, what we had is basically homozygous expression of allele that contain a rare variant that I described before. And this is the way in which we were able finally to prove that in addition to biochemical evidence, we also had genetic evidence for ADA deficiency in this case. So to move on, what is the value really of doing these kind of genetic testing on a large population of patients with primary immune deficiency? What is the actual likely yield, diagnostic yield, if you apply this on a larger scale? And this is something that we did in the UK a few years ago. We had a national study where we collected over 1,000 patients with suspected primary immune deficiencies, and we had some of these patients also had family members included into the study. And this slide here illustrates basically the variety of different primary immune deficiencies that were studied. The vast majority of patients had common variable immunodeficiency, and the vast majority of patients were also adults. So this was mainly a population that had sporadic, non-familial immunodeficiency that was picked up in adulthood. And when we applied whole exome sequencing across all that cohort of just over 800 different cases, we were able to identify the genetic cause in up to 10% of these cases. Given the starting population, as I say, this is unselected, non-familial, non-consanguineous population, we felt that this is a fairly decent pickup rate. In this approach, we were also able to identify some novel causes of immune deficiency as shown in the bottom panel there. But what's overall diagnostic yield if you use this kind of approach across different populations, different countries, different primary immune deficiency cohorts? And you can see here on this table that this varies hugely, being as low as I say, 10% is being quoted in our case series, but as high as 70%, depending really what your starting point is and what your starting population is. And as shown on this slide here, that overall, when you take all these different studies, diagnostic yield is around 30% in kind of unselected groups. But if your starting point is highly consanguineous population, then diagnostic yield might be as high as 57%, whilst in non-consanguinity or sporadic cases that is down to 22%. If you're using whole exome sequencing over, for example, gene panels, that diagnostic yield can be improved further in consanguineous cases, particularly because you can identify some novel genetic mutations. And then if you select your cases on basis of prior functional analysis, so if you have already seen these patients and kind of work them up using standard phenotyping tools such as flow cytometry, immunoglobulin profiling, and all of that, again, you can increase diagnostic even further. And finally, depending on what type of population you're studying, you're far more likely to identify molecular genetic in patients with SCID rather than a common variable immune deficiency. And just to finish with the point of diagnosis and how we can improve that and how we can move the field forward, more recently there have been applications of artificial intelligence in terms of using this approach to again narrow and identify patients who may benefit from further investigations that may have been otherwise missed throughout in the normal run of mills. And this is where, for example, you use clinical information to the known primary immunodeficiency cohorts to then define certain diagnostic criteria, and then you can test these diagnostic criteria on larger cohorts of patients using large databases. And by using this approach, you can pick up patients who whose pre-test probability in terms of having primary immune deficiency is much higher, and you use these tools to pre-select them for testing. And I'm just giving you a couple of most recent examples of the studies which use this to define potentially clinical features and methodological approach by which you can further select patients for investigation of primary deficiency. And to finish off with this slide, really, again, to show another benefit of using, for example, some of these genetic testing in terms of understanding the causes and value added when we're managing patients with primary immune deficiency. This is again the cohort that I showed you previously from the UK that we tested for primary immune deficiencies. But then we also wanted to ask a question whether or not there are any other modifier genes that are not necessarily directly causative of immune deficiency, but may have a role in terms of disease progression and complications. And of particular interest was, for example, whether or not if patients are carriers of other potentially damaging mutations in unrelated disorders, so in this case, CF variants, so cystic fibrosis is caused by mutations in the gene called CFTR, and cystic fibrosis is associated with bronchiectasis. And what we wanted to know here, if you're a carrier of the pathogenic CFTR variant, is there more chance of you developing lung structural damage on the background of also having primary immune deficiency? And to cut a long story short, the answer is yes. So if you're a carrier of some of the more common pathogenic CFTA variants, you don't necessarily have cystic fibrosis. That carrier status makes you more likely to develop structural lung disease on the background of primary immune deficiency. What this suggests that maybe if we were to genetically test patients for primary immune deficiency, it is not only important to make diagnosis of primary immune deficiency, but also to find other genetic variants that their clinical cause and their outcomes. And in this case, if you do find a patient who is also a carrier of cystic fibrosis gene, then such patients may need more aggressive treatment development of lung complications. And this is where I would like to finish, and I thank you for your attention. and I will do my best to be there to take some questions in the live Q&A session. Thank you again for your attention.
Please go out of the room.
The next invited speaker is Dr. Masroor Ilahi Babar. And he will speak on can we make mankind immune to avoid vaccinations against major viral diseases through gene editing. Dr. Masroor Ilahi Babar, the former Vice Chancellor of Agriculture University, D.A. Khan, was honored with the prestigious Tamgha Imtiaz for his exceptional contributions to the field of science in 2012. Dr. Babar holds a PhD in animal breeding and genetics, complemented by postdoctoral fellowships in animal genomics from Canada and functional genomics from the United States. His remarkable academic career spans multiple impactful research publications with cumulative impact factor more than 100. I'll invite Dr. Masroor Ilahi Babar.
Thank you very much for all of you, especially the organizers and the chair, and very, very learned professors here who are present. मेरा इम्पैक्ट फैक्टर 200 से भी ज़्यादा है और कल अल्हम्दुलिल्लाह मेरा नेचर में भी पेपर छप रहा है जिसकी वजह से मुझे बहुत अच्छा खुशी महसूस हुई। इसके अलावा मुझे एक बुक से भी जो पिछला लेक्चर बहुत अच्छा था लेकिन मैं उसमें जस्ट एक ऐड कर दूँ कि होल एग्जाम और होल जीनोम से ज़्यादा आपकी पैथोलॉजी में पर्टिकुलरली जो है ट्रांसक्रिप्टोमिक एनालिसिस अगर आप करवा लिया करें तो उससे बहुत ज़्यादा बेहतर हो जाता है क्योंकि वो ट्रांसक्रिप्टोम्स जो पर्टिकुलरली लिवर या अदर डिजीज में होती हैं उससे बहुत फर्क पड़ जाता है। My approach is, our approach is a little different for the immunity in the human body because there are two things normally the doctors are doing. One is you can vaccine, or the other thing is you can have the treatment for that. Like our approach is a little out of box approach. You can say exactly जिसको मैं उर्दू में कहूँ कि चोर को नहीं चोर की माँ को पकड़ ले और अगर चोर की माँ को पकड़े it means कि if you are controlling a problematic person you can definitely control the whole problem और अगर वो चीज़ आ जाए तो हम देखेंगे कि कैसे जेनेटिक लेवल पे हम जीन एडिटिंग कर लें और इम्यूनिटी में इतनी ज़्यादा रेजिस्टेंस ले आए बल्कि 100% रेजिस्टेंस ले आए एंड दिस इज नॉट ए कोई क्या सितारों का इल्म नहीं बल्कि ग्राउंड रियलिटी और मैं भी आपको दिखाता हूँ कि व्हाट वी डिड व्हाट द पीपल आर डूइंग हाउ दे आर डूइंग सो व्हाट इज जीनोम एडिटिंग और जीन एडिटिंग इट कैन ऐड रिमूव और alter your sequence at what stage. It may be at sperm, in the sperm, in the ova, or maximum to the zygote stage. Because as the multiplication will start, you have to make the changes in each cell, or each cell may change karna. Remember, there are many restriction enzymes. We are also playing with the restriction enzymes. लेकिन अगर आपके restriction enzyme ने आपकी human के fertilized ova को काट दिया, डीएनए कट गया और अब एक अंदर से कुदरत का निजाम है मैकेनिज्म है जो उसको जोड़ने पे लगा तो देयर विल बी अनऑर्गेनाइज्ड रिपेयर सिस्टम वो इनिशिएट हो जाएगा ऑन हो जाएगा और आप उसको संभाल नहीं सकेंगे उसमें एडिशन होनी शुरू हो जाएंगे डिलीशन तो जीन एडिटिंग करना काटना तो बहुत आसान है लेकिन उस काटने को दोबारा ऑर्गेनाइज जोड़ के उसको दोबारा फंक्शनल करना सेल के अंदर डालना और सेल को reproduction की तरफ ले जाना is actually a little there are many tools for gene editing जो दो पहले यूज हो रहे थे ZFNs zinc finger nucleases और TALENs transcriptional activator like effective nucleases ये दोनों बहुत अच्छी लेकिन प्रॉब्लम ये था कि ये दोनों डबल स्ट्रैंडेड ब्रेक्स करते हैं एक प्रॉब्लम दूसरा ये है कि रिपेयर मैकेनिज्म को जो है वो कंट्रोल्ड नहीं रखते और दोनों की वजह से ऑफ टारगेट जो है वो कुछ चीजें एडिशन डिलीशन शुरू हो जाती है जिसकी वजह से वो आपसे संभलेगा नहीं और वो कोई फायदा लेने के बजाय जो आपने कटिंग करनी थी और उसके बाद उससे कोई रिजल्ट निकलना था, वो हैप्पैजार्ड की वजह से उसके नुकसान ज्यादा होने शुरू हो जाते हैं। और आप देयर आर मेनी रिस्ट्रिक्शन एंजाइम्स, लेकिन वो काटते बहुत सारे हैं। तो ये जो है ये काटते स्पेसिफिक साइट पे तो काट देते हैं, लेकिन उसको रिपेयर जो है वो अनप्लान्ड कर देते हैं। इसमें क्रिस्पर आया जो बेसिकली क्लस्टर्ड रेगुलेटरी इंटरस्पेस शॉर्ट पैलेटोमिक रिपीट्स हैं, जो हर पर्टिकुलरली सबसे पहले तो बैक्टीरिया में देखे गए और उसके बाद देखा गया कि सारे प्रोकैरियोट्स में मौजूद हैं। और ये इतने खूबसूरत रिपीट्स हैं जिनको आप यहाँ पे देख लें, वहां से आप उसको रेस्ट्रिक्शन कर सकते हैं और उसके बाद आप इसको सबसे पहले ये इकोलाई में 87 में ये देखा गया। उसके बाद जो है वो क्रिस्पर जो है सारे प्रोकैरियोट्स में देखा कि ये सारे मौजूद है। Cas9 हम इस वक्त देखेंगे कि Cas9 की Cas11, Cas12, Cas13 और CPF1 जो हमने फर्स्ट टाइम इन द वर्ल्ड शुरू किया, ये हम आपको दिखाएंगे कि कैसे हमने इसको काटा और कैसे इसको आगे 2011 में पता लगा कि क्रिस्पर तो सारे प्रोकैरियोट्स में यूज हो रहा है और इसकी एडिटिंग में बहुत सारा काम हो जाता है। 12 और 13 एक क्रिस्पर की लड़ाई का साल था, जिस तरह एरोप्लेन पे झगड़ा पड़ा रहा, राइट ब्रदर्स ने बनाया, किसने बनाया। अल्टीमेटली 2020 में इन दो खवातीन ने नोबेल प्राइज इसका विन किया, जो काफी लंबी इन्होंने डिबेट और कोर्ट केसेस जीत के। ये है एक बैक्टीरिया और इसका ये क्रिस्पर एरे है, जिसमें आप देख सकते हैं कि एक पेनेट्रोपिक सीक्वेंसेस हैं, शॉर्ट स्पेसेस भी हैं, कुछ रिपीट्स भी हैं, और ये सारा जो है वो पैलिंड्रोमिक रिपीट्स हैं जो 20 to 40 बेस पेयर के हैं, जहां से ये काम हम शुरू करेंगे। हाउ दिस वर्क्स, ये यहाँ पे मैं आपसे थोड़ा सा देखूंगा कि ये गाइडेड आरएनए है, ये पूरा सिस्टम Cas9 है। इस गाइडेड आरएनए ने आपको दिखाना है कि कहां पे जाके आपने इसको काटना है, और ये कट गया, डबल स्ट्रैंड इस वक्त कटा हुआ मौजूद है। अब यहाँ पे एक तो तरीका ये होगा कि नॉन होमोलोगस एंड जॉइनिंग शुरू हो जाए, जो हम नहीं चाहते, क्योंकि नॉन होमोलोगस कुदरत के निजाम पे चलेगा और वहां से अगर वो दोबारा जोड़ देगा तो देयर आर मेनी चांसेस कि कुछ एडिशन डिलीशन म्यूटेशंस हो गई हैं, हो सकता है वो उल्ट जुड़ जाए, जिसकी वजह हमें इस सारे को कंट्रोल करके लाना पड़ेगा कि ये होमोलोगस ओवरलैप्स की तरफ आए, और ये जुड़ने के बाद यहाँ आपका डिजायरेबल जो है वो पीस यहाँ पे लगे और ये पीस लग के अपने दोबारा वापस फंक्शन में जाए। और उसको ये देखिए, ये है एक बैक्टीरिया का क्रिस्पर रीजन जिसमें एक फेज ने अटैक किया। जब भी ये फेज अटैक करेगा तो याद रखें कि फेज के कुछ हिस्से, कुछ जीन्स जो हैं, ये क्रिस्पर के अंदर जुड़ना शुरू हो जाए। ये एक दफा जिस पर फेज ने अटैक किया तो इसने कुछ हिस्से यहाँ लाके इसको जोड़ दिए, लेकिन जिस वो दोबारा सेकंड फेज आया और उसने अटैक किया तो पहला जो उसका पीस आया हुआ था कुछ जीन्स का, वो एक्टिवेट हो गया। एक्टिवेट हुआ तो बैक्टीरिया का अपना Cas9 जो है वो उसके मुकाबले में आया, और जैसे ही वो मुकाबले में आया तो उसने Cas9 ने गाइडेड आरएनए लिया और उसके साथ जाके तो ज्वाइन कर दिया यहाँ पे आके, और ज्वाइन करने के बाद उसने जो है उसको डिग्रेड किया, और नेक्स्ट टाइम जो है वो उसका अटैक जो है उसका बिल्कुल तकरीबन खत्म हो गया, और वो उसकी वो सेवेरिटी और वो उसका इफेक्ट नहीं रहेगा जो फर्स्ट टाइम पे उसने उसको डैमेज किया। पूरे क्रिस्पर Cas9 की थ्योरी में एक चीज है, जैसे मैंने आपको बताया कि Cas9, 10, 11, 12 जो बेसिकली Cas जो है वो कट करता है डीएनए। गाइडेड आरएनए जो है वो बिल्कुल उसी तरीके से जिस तरह पीसीआर में जो है वो प्राइमर का किरदार है, वो प्राइमर की तरह जो है वो गाइडेड आरएनए जाके तो साइट को लेके आएगा, और उसके बाद एक बहुत खूबसूरत पैम रखना होता है जो फोटोस्पेसर जैसे मोटिव्स हैं, जो एनजीजी की सूरत में 3 बेस पेयर को आइडेंटिफाई करेंगे कि ये अपने को तो नहीं दोबारा जोड़ने लगा, ये फॉरेन का कौन सा डीएनए, और ये उसको आइडेंटिफाई करवाएगा कि कहां पे अपने को नहीं बल्कि दूसरे के पीस को जोड़ के तो यहाँ पे उसको इंसर्ट करना है ताकि वो दोबारा रिपेयर शुरू हो। हमने ये सारी टेक्निक सीखी आज से 5-7 साल पहले जाके चाइना से जाके, यहाँ पाकिस्तान में भी सीखा जो कि मेरा बेसिक फील्ड एनिमल्स का था। तो हमने देखा कि हमारी तमाम शीप जो है वो सिंगल मसल की हैं, तो हमने कहा क्यों ना हम इसको देखें कि सिंगल मसल में म्यूटेशन कौन सी है, और अगर हम उसकी जगह दूसरे को ले लें तो ये जिससे हमने चेक किया तो सारी की सारी हमारी शीप सिंगल मसल थी। हमने ये 6723 पे देखा कि जी अगर ए में ट्रीट होते एक सिंगल एलील से तो ये डबल मसल हो जाती है। डबल मसल शीप जैसे अगर आपने गायों में देखा फॉरेन की बड़ी हैवी किस्म की होती हैं, ये 20 to 30% जो है ये ज्यादा मीट देती हैं और पाकिस्तान की शॉर्टेज के लिहाज से तो हमने वही सारी टेक्निक जो है इंसर्शन की जो है वो उसकी लिया, डीएनए को कट किया, वहां से उसको जाइगोट में डाला, जाइगोट को वापस जो एक्टिवेट किया दोबारा प्राइम, और उसको जो है वो वहां तक तो हमने किया कि जाइगोट में उसको मुकम्मल करके, लेकिन उसको दोबारा इंसर्ट करना और शीप की प्रोडक्शन जो है ये अभी इन प्रोसेस है। कई और प्रोजेक्ट्स हैं जो गाय भैंस में, और फिर हम आपको कहेंगे कि ह्यूमन में कैसे इसको, फॉर एग्जांपल मिल्क प्रोडक्शन या मीट को इंक्रीज करना, फुट एंड माउथ एंड मेनी अदर वायरल डिजीजेस जिनके खिलाफ बड़े इजीली जो है ह्यूमंस में, एनिमल्स में और इवन ह्यूमंस में हम रेजिस्टेंस ले सकते हैं। वायरल एंड जो रानी के न्यूकासल डिजीज एंड मेनी पोल्ट्री, सबसे ज्यादा जो जरूरी चीज है जो अभी इंप्लीमेंट भी हो गई कि चिकन के एग्स में इंटरफेरेंस नेचुरली इंसर्ट किया गया। अब जो एग आ रही हैं और मिल्क आ रहा है वो नेचुरली इंटरफेरेंस के साथ है, आप उसको नॉर्मली यूज करें दैट, और उसके बाद कोई ऐसी प्रॉब्लम नहीं रहेगी वजह सारी से। ये पिछले दिनों ये पोस्ट कोविड आपने लिखा हुआ है, कोविड के लिहाज से फिर ये स्ट्रिप्स तैयार की गई जिसमें Cas9 का इस्तेमाल किया गया और कोविड की आइडेंटिफिकेशन के आप जाते हैं लैब में, लैब के टेस्ट और डिफरेंट प्रोसीजर्स, व्हाई नॉट टू हैव ए शॉर्टर स्ट्रिप, जैसे आप लोग ये प्रेगनेंसी डायग्नोसिस की या और कोई शुगर या इस तरीके की यूरिन के कोई टेस्टों में इस्तेमाल कर, ये स्ट्रिप होगी जो। अब हम देखते हैं कि पैथोजेंस काम कैसे करेंगे और पैथोजेंस में चेंजेस क्या लाएंगे और जिसकी वजह से आप डिजायरेबल इम्यूनिटी जो है वो बॉडी में इंक्रीज कर सकते हैं। देयर आर टू प्रोसीजर्स, वन इज जीन नॉकआउट करने, आप Cas9 करें, आप ये पर्टिकुलरली उन केसेस में जहां पे रिसेप्टर्स जीन ज्यादा होते हैं, आपको कुछ अटैक हुआ और आप कहते हैं कई दफा आपने देखा फ्लू हुआ या कोई और चीज हुई, कुछ लोगों को वही सारा माहौल है, वही सारा कुछ है, कुछ को हो जाता है, कुछ को नहीं हो रहा। आप कहते हैं these are naturally immune people, genetically immunity में ज्यादा है, क्यों ज्यादा हो जाती है? हम देखते हैं कि वहां पे कुछ जीन्स हैं जो ज्यादा आपको ससेप्टेबल बना रहे हैं, अगर आप उनको एट अर्ली स्टेजेस उसको नॉकआउट कर दें। दूसरा तरीका ये है कि आप कुछ जीन्स को ऐड कर दें, ऐड करने वाले डेफिनेटली आपकी ज्यादा इम्यूनिटी करेंगे। जो नॉकआउट कौन से होंगे? जो वायरल रिसेप्टर्स हैं, जबकि नॉकआउट कौन से हो सकते हैं? जो इम्यूनिटी बूस्टर्स हैं। आप दोनों तरीके कर सकते हैं कि या अपनी इम्यूनिटी को बढ़ा लें या जो आपकी ससेप्टेबिलिटी है उसको रिड्यूस कर लें, दोनों तरीके से आपकी जीन। फॉर एग्जांपल मैंने एक मिसाल दी है, CCR5 जीन जो है ये वायरल रिसेप्टर के लिए जो है बॉडी में ह्यूमंस में बहुत ज्यादा इफेक्टिव है, यानी रोल प्ले कर रहा है। अगर आप इसकी वेरिएशंस को नॉकआउट कर दें, इफ यू फील, जो अभी मैंने आपको कहा कि वेरी गुड साइंटिस्ट वाज सेइंग कि होल जीनोम के होल एग्जाम कर लें, व्हाई नॉट कि आप ट्रांसक्रिप्टोमी करें कि होल एग्जाम कर लें, और अगर आप देखें कि वाकई ससेप्टेबिलिटी आपके ज्यादा हो रही है तो आप फिर इसकी प्लान कर लें। मैं भी आपको दिखाऊंगा जो ह्यूमन में अभी रिसेंटली जो हुआ और जो फिर साइंटिस्ट के साथ सलूक हुआ, यहाँ पे आप इंटरफेरॉन वगैरह को आप बूस्ट के लिए, अच्छा यहाँ पे जिस तरह होता है कई सेगमेंट्स होते हैं जो आपके कारामत हों तो आप उनकी मल्टीपल कॉपीज भी लगा सकते हैं। ये कुदरत ने निजाम दिया कि आप, यानी आप फॉर एग्जांपल एक मजदूर जितना काम कर रहा है तो दो उससे डबल कर लें, तो उतना पार्ट जो है आप डबल फॉर्म में ले आए जो आप इंसर्ट करके ये आप इंटरफेरॉन जीन्स को जो है वो आप इन कर सकते हैं और बड़े आराम से आपका डीएनए जो है वो रिपेयर होगा और नॉकआउट में ये मैं आपकी लास्ट स्लाइड है और मैं आपको दिखाऊं कि 2018 में जो है ये चाइनीज साइंटिस्ट था, इसके पास एक फैमिली है, दोनों जो थे HIV पॉजिटिव थे और दोनों कंफर्म केसेस, और दोनों ने आके कहा कि हमें एक बच्चा चाहिए लेकिन हमारी ख्वाहिश है कि शायद हम मर जाएं लेकिन हमारा बच्चा नहीं मरना चाहिए, तो आप कुछ करें हमारे साथ कि क्या किस तरीके से ये ले सकते हैं। उसने जेनेटिकली मॉडिफिकेशन की, उनके दोनों के वो लिया, स्पर्म लिया, दोनों में मॉडिफिकेशन की, दोनों में जो है HIV के जीन्स निकाल दिए। दोनों का जाइगोट बनाया, दोनों का मिलाप करवाया और लोलो और नैना जो है वो दो बच्ची, उन्होंने दो जाइगोट लिए कि शायद एक चल जाए दूसरा ना चले, तो उन्होंने दोनों लिए और दोनों को इंसर्ट किया मदर में नेचुरल। लेकिन हुआ क्या कि दोनों कामयाब रहे और दोनों बच्चियां पैदा हो गई। एट द मोमेंट द टू बेबीज आर वेरी मच हेल्दी। वालिदैन दोनों मर गए, दोनों बच्चियां जिंदा हैं, दोनों जो है HIV नेगेटिव हैं, दोनों हेल्दी हैं, दोनों जिंदगी गुजार रही हैं। और लेकिन क्या किया हमारे लोगों ने साइंसदान के साथ, उन्होंने कहा कि विदाउट परमिशन आपने ये काम किया, उसको इतना हैवी जुर्माना किया कि उसको दिवालिया कर दिया और वो इसको बड़े बुरे हाल में बैठा हुआ है। इन्होंने कहा ह्यूमन पे काम भी नहीं कर सकते थे, आपने ये कैसे इसको कर दिया। उसने मैनकाइंड के लिए जो कुछ किया वक्त बताएगा, लेकिन बंदा जो है निशाने इबरत बन गया और एक सक्सेस स्टोरी छोड़ गया। दिस स्टोरी इज क्लियरली टेलिंग कि द if Lolo and Nana are living healthy without any problem, why not we can eliminate the undesirable genes, susceptible genes in the body, and the people are doing in animals. We are doing a lot of good experiments, techniques are confirmed. There is a need कि out of box हम लोग human पे थोड़ा सा ट्राई लें, रिसर्च करें, इस फील्ड में आगे चलें और इस स्टोरी को कामयाब करें। The techniques are available in Pakistan. Why not to join hand to have more work? Thank you very much.
The house is open for questions.
Yes, sir.
Thank you very much. What an illuminating talk and ideas. Do we have any successful animal models? And was the last experiment published anywhere, or is it just a story which is transferred between individuals?
Sir, animals में not one, hundreds of success stories. ये मैं बता रहा हूँ कि ये सारा कुछ, for example, foot and mouth resistant animals. Yes, these are animals available. ये जो डबल मसल है, ये हमारी, if you know, कि हम लोग आमतौर पर रिगर्जिटेटेड रिसर्च करते हैं, हमारे यहाँ ओरिजिनल रिसर्च। इफ वी आर डूइंग दिस वन, वी टुक द आइडिया फ्रॉम अब्रॉड, और ये इसकी हंड्रेड्स हैं। मैं तो आपको ह्यूमन की एग्जांपल दे दूं कि जिसमें ह्यूमन में वो दो बच्चियां पैदा करके और 18 से अब तक वो, तो ये एस्टैब्लिश टेक्निक है, इस वक्त कंफर्म्ड ये सारा कुछ हो रहा है। मिल्क प्रोडक्शन में कहीं आगे ले गए, ग्रोथ को इतना तेज कर दिया, ये सारा वो हो गया। अनफॉर्चुनेटली, क्योंकि फॉर एग्जांपल मैं आपको एक छोटी सी ज्यादा बहस नहीं करूंगा, वाइस चांसलर था, मिलियंस ऑफ पैसे मेरे पास थे, मैं कुछ माइक्रोस्कोप इक्विपमेंट खरीदना चाहता था, मैं वो फाइनेंस डिपार्टमेंट इस्लामाबाद से परमिशन ही ना ले सका कि 4-6 लाख डॉलर मैंने ये इस इक्विपमेंट पे लगाने हैं। उन्होंने कहा डॉलर मुल्क में नहीं है, आप खरीद नहीं सकते। तो यहाँ नहीं हो रहा, बाहर सारा।
You talked about interferon in milk and egg. Which interferon and what's the idea?
असल में जो एग और उसकी प्रोटीन बन रही है चिकन के अंदर, वहां पे उसकी कंपोजिशन जिस वक्त बननी है उसमें चेंज लाई गई। वहां चेंज किया गया कि उसकी कंपोजिशन जिस वक्त बननी है तो उसमें चेंज लाई जाए, और पीपल हैव डन ऑलरेडी, ये भी हो चुका है, ये बाहर जो है ये, और उसमें और कई चीजें भी डाली गई हैं जिससे उसकी, फॉर एग्जांपल जो जिन फॉर एग्जांपल लोगों को कुछ खास प्रोटीन से एलर्जी है उनको निकाला भी गया, कुछ बच्चों के लिए ज्यादा ग्रोथ के लिए जो जरूरत की चीजें वो डाली भी गई। तो ओके, एक चीज मैं बताना भूल गया, दिस टेक्निक इज ए अप्रूव्ड टेक्निक, लेकिन जो जेनेटिकली मॉडिफाइड एनिमल्स या प्लांट्स का जो है दैट इज ए डिस्प्यूट। आपने पिछले दिनों देखा सोयाबीन रोक दिया, सोयाबीन रोका तो वो पोल्ट्री के रेट्स कहाँ चले, वो तो है अभी डिस्प्यूट। देयर आर मेनी कंट्रीज, यहाँ आपने कोई खास नहीं किया, आपने जो दो चीजें थी, एक फॉर एग्जांपल मेरे अंदर मोटे होने की चीज है और पतले होने की चीज है, दोनों तरह की मौजूद है, कुछ में एक्सप्रेशन किसी का हो रहा है किसी में नहीं हो रहा, तो हम वो जो डिजायरेबल करवाना चाहते हैं उसको एक्टिवेट करवा देते हैं और दूसरे को जो है वो साइलेंट करवा देते हैं, ताकि, तो इसमें कोई प्रॉब्लम नहीं है, कानूनी लीगली इस्लामिक हर लिहाज से ठीक है। और
So I have a question. Ethically, we are allowed to modify genes in human babies in
हम तो
Pakistan?
हम तो मॉडिफाई कर ही नहीं रहे ना। मैंने बताया genetically modified is a controversial issue. हम
In
नहीं
human
मानते।
babies or animal babies? Which babies? In humans or animals?
देखिए genetically modified हर जगह पे disputed है, कुछ कंट्रीज ने इजाजत दी है। अमेरिका के 70% टमाटर जो हैं वो जेनेटिकली मॉडिफाइड
सर टमाटर तो वेजिटेबल
मैं
है,
सिर्फ
इंसानों
एक
की
बात
बात
कर रहा हूँ कि होता ये है कि जब आप कोई जेनेटिकली मॉडिफाइड चीज खा लें, चाहे वो एनिमल की सूरत में खाएं, प्लांट्स की सूरत, तो आपके अपने अंदर जो है वो चेंजेस आने के चांसेस है, क्योंकि वो चीजें म्यूटेशंस के तो जेनेटिकली मॉडिफिकेशन इज ए डिस्प्यूट, लेकिन जीन एडिटिंग इज नॉट ए डिस्प्यूट।
So we can have, sir, okay.
दोनों different चीजें।
Last question and then we'll have another speaker.
Okay.
Just one question in line of what Professor Tahir said. The interferons, any type of interferons, alpha, beta, gamma, if you are going to insert the genes by gene editing, it may also have a negative impact, not only the positive. If you are inserting it into the eggs and the people are getting it. So there is one concern.
This is very, very, very important. I think really the sense यही है। तो ऐसी किसी भी किस्म की चीज करने से पहले 10 दफा सोचना पड़ेगा कि आया ये हम जो काम करने लगे, और इसीलिए वो रैट मॉडल, रैबिट मॉडल और उसके बाद बेशुमार तजर्बा, और ह्यूमन में खुदा ना खासा ऐसी कोई काम करने लगे जो ये चीज खिलाने लगे, उससे पहले 100,000 दफा
Thank you, sir. Thank you very much.
डिस्प्यूटेड से ज्यादा बहुत ज्यादा सोच विचार की।
Thank you.
Thank you. Thank you.
Nawaz Tipu is going to talk about next generation sequencing in immunology, current status and future directions. Lieutenant Colonel Hamid Nawaz Tipu is an esteemed consultant immunologist at CMS Lahore. He is a distinguished professional in the field of immunology. Graduating with an FCPS Immunology in 2009, he brings extensive expertise in specialized domains such as flow cytometry, immunogenetics, and immunoinformatics. With a commendable track record, Lieutenant Colonel Hamid Nawaz Tipu has contributed significantly to the field with over 50 publications, demonstrating his profound knowledge and dedication to advancing the understanding of biological science. Over to you.
Bismillahirrahmanirrahim. Thank you very much, ma'am. I am Dr. Hamid Nawaz Tipu. I am working in CMH Lahore, and I shall talk about the next generation sequencing in immunology, its current status and future directions with particular reference to Pakistan. What I shall discuss is that the introduction of sequencing, followed by HLA typing, by NGS, the various methods and approaches available, and its applications for the diagnosis of inborn errors of immunity that has already been touched upon by Professor Sinak. The sequencing was initially, as most of us are aware, was introduced as a first generation sequencing called Sanger sequencing by Maxim and Gilbert as the Sanger chain termination method that employed dideoxynucleotide triphosphates. However, it was limited to few hundred base pair of fragments only. This was followed by next generation sequencing by companies like 454, Solexa, Iron Torrent, and Illumina. It's a high throughput from the parallelization of sequencing reactions, but it was also limited to short base pair fragments up to 500 base pairs only. And recently, third generation sequencing technologies have been introduced by companies like Pacific Bio and Oxford Nanopore that can sequence native DNA in real time with single molecule resolution and can sequence tens of kbs of fragments. So this is the long-read sequencing technologies. Various approaches used in the NGS are, as already told by Professor Savek, are the targeted gene panel sequencing that are used for the categorical genetic disorders, for those diseases for which the mutations are mostly already identified. Hundreds of genes can be targeted at a time. It has high coverage and high depth at a lower cost. The other approach is the whole exome sequencing and the genomic sequencing technologies can target a higher portion of the genome, or it can target all the exons and it can target the whole genome, but at higher cost and low coverage and depth. This graph shows that with the introduction of genomic technologies, especially the NGS, the cost of sequencing per gigabase is drastically reduced from several thousands of dollars per gigabase to few $100, and especially with the introduction of high throughput sequencers. I shall briefly touch upon the Illumina sequencing by synthesis chemistry because this is Illumina holds 70% of the market share, and about 90% of the world's genetic data has been produced using Illumina-based methods. So it starts from here, the library preparation. The genomic DNA is fragmented into small pieces with the help of sound or the enzymes, and then the small pieces of DNA called the adapters are ligated to the ends of these DNA, and a sequencing library is formed. This library is loaded onto a flow cell, and the fragments are hybridized to the flow cell surface. Each bound fragment is amplified into a clonal cluster through a process called bridge amplification. This is the initial clonal amplification of the target genes. This is followed by the sequencing reaction, whereby sequencing reagents, including fluorescently labeled nucleotides, are added and the first base is incorporated. As the fluorescence is generated, the image is captured, and this cycle continues for n number of times to create a read length of n bases. And finally, the alignment and data analysis, whereby the reads are aligned to a reference genome with the bioinformatics softwares. And after alignment, the differences between our reads and the reference genome can be identified and computed. With particular reference to immunology, the NGS can be used for the diagnosis of inborn errors of immunity, commonly known as primary immunodeficiency disorders. For HLA typing, identification of genetic disorders, for autoimmune disorders, autoimmune diseases, pathogen identification and surveillance, and B and T cell receptor profiling. These are the various HLA typing techniques most of us are aware with. Sanger sequencing until recent past was considered gold standard because it could resolve up to high resolution HLA, but it has limited coverage. It can sequence only up to 1000 base pair of fragments. The cost and initial investment is high with limited batch testing possible, and it suffers from phasing issue. NGS is also able to resolve to highest resolution, and it can resolve the phasing issue. As in the Sanger sequencing, all the exons are sequenced separately for HLA typing, and it is really not possible to determine that which exon lies with which of the haplotype on which of the chromosome. So these cis and trans ambiguities can be resolved with the help of NGS. This is the standard HLA nomenclature. Typing for the first two fields is considered sufficient to call it high resolution typing. These are the kits we used in the AFIP for performing HLA typing NGS, and using these instrument and the kits, it is possible to do the NGS for about 24 samples at all of the class 1 and class 2 loci up to 3 field resolution. And it's possible to, for starting from a genomic DNA, it is possible to take the report to patients the second day of taking the sample to all the 24 patients. So very briefly in touching upon the steps of NGS, the DNA is quantitated and locus-specific amplification is done. For some of the loci, the whole gene is sequenced, amplified. But for other of the loci, the whole gene, it is not possible to sequence the whole gene because for these loci, because the intron 1 is very large. But still, these include exons 2 and 3 that are essential for high resolution typing. After amplification, the gel electrophoresis is run, and this is the expected amplicon size for various loci. The amplicon quantitation is done followed by the exosite party purification, fragmentation of the DNA, and repair, ligation with adapters that are used finally for the identification. These are the various adapters or the indices that have been used for labeling the different samples. And the library, pulling all the samples are combined together for sequencing finally. Bead-based library size selection is done with the help of AMP pure XP beads that use solid phase reversible immobilization chemistry, means that they can bind to a specific size of the DNA fragments. Finally, DNA quantitation is done, followed by sequencing on the MySeq instrument. We use the microflow cell. There are different flow cells available with various capacities. This flow cell can sequence 24 samples if 7 loci are being sequenced. Illumina control software used with automatic demultiplexing. This is the bridge amplification being done, the clonal cluster being amplified on the flow cell. The sequence analysis we were doing the sequencing, it shows the different tiles on the flow cell, and these are the cycles, 150 cycles for the nucleotide addition in one direction, And since it's a parent sequencing, the sequencing is run in both directions for DNA, the next 150 cycles, and the Q scores showing, the Q30 showing above 95% for the reads. This is just the different cycles ongoing, the sequence analysis viewer, the nucleotides being added, and the images being captured in the flow cell with demultiplexing being done. Final analysis done with using Agile Twin software that uses consensus genotyping and statistical genotyping algorithms. Here we can see a sample being aligned against the reference genome. It has been resolved to A02010101, and this is the reference genome. And here we can see the junction, the bonding between intron 2 and exon 3. The sample being aligned against the reference genome. There are several quality control parameters that are checked during the NGS. There are certain primary QC parameters like the read count, noise ratio, exon spot noise ratio, key exon, consensus coverage, key exon allelic imbalance, and genotype availability in the reference genome. And there are certain secondary QC parameters. All of these parameters have to be clear before calling the alleles. And this is after allele calling. For this particular patient, actually DP tapping has not been done. And we can see that these are the alleles being called for a particular patient. More than one alleles can be called at 8-digit resolution since soul of the genome is not covered. But we can see that all of these match at 3-field level. And this is the final report given to the patients. The father, all of the family has been typed using NGS. This is the actual report. The father is typed as allele 1 and 2, mother 3 and 4. The patient carries allele 3 and allele 1. And the patient does not have any full match in the family. So when the results are compared for HLA mismatches, low resolution versus the high resolution HLA typing, the mean number of mismatches increases from 2.6 to 4.1, and others for all of the loci. Those matches that are initially considered match at the low resolution then become mismatch at the high resolution. And when it is applied at the clinical level, especially for the bone marrow transplant recipients, their probability of survival decreases if there are more number of mismatches at the high resolution. So comparing our results, we did the 48 patients and 96 data points at each of these loci. The concordance of NGS with SSP, the previously established method, was 99.3%. Only two alleles differed, B58 versus B57 and C12 versus C05. But these alleles already have over 99% sequence homology. So it's quite possible that SSP could have read a different allele. And the commonest alleles in our study is 02 versus a 02, B51 versus B35. But we know that both of these alleles are very common in our population, C07 versus C07. This difference could be due to a difference in the target population. Our sample size was limited to 96 data points, and different techniques were employed. They used SSP and SSO. So comparing these techniques for the application of HLA typing, and with the help of NGS, it is possible to sequence about more than a dozen samples at one time with several of the loci at the highest resolution possible. But turnaround time is high and cost is definitely higher as compared to SSP. These issues have been resolved with the help of Oxford nanotype sequencing. Oxford nanotype sequencing is the third generation sequencing techniques, the long-range sequencing techniques. Its principle is that the DNA in the form of a single molecule is passed through a nanopore with the help of a motor protein. And as a single molecule of DNA passes through this nanopore, due to the difference in nucleotide bases, there is difference in the electric current generation, the voltage generation. And this is used to identify the nucleotide bases and finally deduce the sequence. Definitely the advantage is that no capital investment in the terms of equipment is required, and it is possible to do all of the sequencing in this small flow cell, which can be directly attached to a laptop. This I think is already shown by Professor Savik, just shows that for the important of immunity, It's a group of disorders caused by germline mutations that affect different parts of the immune system. Professor Savik already told that number of genetic defects has drastically increased with the introduction of sequencing technologies, especially in the last 1 or 2 years. The different approaches he has discussed, there are different approaches to diagnosis of IEI with the help of NGS. The targeted gene panel, a panel of known genes is used for the diagnosis. The cost is different, about $500. Advantage is that it is customizable and you can actually select the genes, which genes have to be sequenced. Only limited variants can be identified, the previously known mutations. And for the whole exome sequencing, the 2% genome can be sequenced. The cost is high, but novel mutations in the exomes can be identified, and also the non-coding and structural variants. Using conventional techniques like Sanger and karyotyping and the microarrays, it is possible to identify 15% of the PID patients in an unselected population. But with the use of these whole exome and the TGP sequencing, about 40% of the patients can be diagnosed. For the whole genome sequencing, the entire genome is sequenced and novel and the structural variants in the genome can be identified, but the cost and the complexity of data analysis is very high. In the whole genome sequencing, the challenges remain like the identification of variants. There are different types of variants that are classified as pathogenic, likely pathogenic, benign, and the variants of unknown certainty, unknown significance. Whatever approach is used for the diagnosis of IEIs in the sequencing, finally the bioinformatic analysis forms a bottleneck. Variants once identified, then we have to exclude the synonymous mutations and the polymorphisms in the genome. Variants have to be prioritized using the assumed inheritance pattern of the disease. Then in silico prediction of the variant effect is done using tools like polymorphism phenotyping, sorting intolerant from tolerant, and mutation taster. And the previously reported mutations associated with the human disease have to be identified. Novel mutations are prioritized using existing knowledge of gene function. And finally, functional validation of these variants may also be required. This is our collaboration with Professor Raif Behar Laboratory in the United States. Many of you are familiar with this collaboration. And these are the results of NGS for the suspected PID patients. And we can see that most of our patients have been diagnosed with a mutation, but this is a selected population. The patients already diagnosed of having the primary immunodeficiency. So the diagnostic yield is definitely very high. And similar is for their collaboration in Karachi. The diagnostic yield is about 85%. This diagnostic yield definitely increases with the variant effect. The higher a variant exerts its effect, its phenotype expression, the diagnostic yield is high if the allele frequency is low, especially like the diseases like SCID and the CVID. There are different commercial laboratories in Europe and United States that are offering the primary immunodeficiency panel analysis for patients. It is a customizable panel whereby they offer you a panel of different genes and you can actually select the different genes for analysis. The results are usually available in 1 to 2 months' time, and the cost is about $1,000+. The cost is very high for this analysis. And this is how the results are given. Like this particular patient is homozygous for RNA component of mitochondrial RNA endonuclease, which is a pathogenic variant in the cartilage hair dysplasia. Thank you very much, but no such facility of PID diagnosis is available in Pakistan so far. Thank you very much.
Thank you very much. What a pleasure. I was just thinking, would it be possible for you to go through what is available or what may be easily available with different suppliers and vendors and come out with a sort of currently recommended solution primarily for two areas. One is tissue typing and the other is diagnosis of immune deficiency. So just for guidance of whoever may take the initiative and has the resources.
So regarding HLA typing, there are already kits available, and as I have shown that we have already done HLA typing. Primarily, the equipment is provided by the different vendors like Illumina and 454, but I think Illumina is more common in Pakistan as well. And the kits, especially with particular reference to HLA typing, are provided by Omixon, I am aware of. There might be some other kits, like I think they are provided by Thermo Fisher probably, or one lambda, but there are other HLA typing kits for NGS also available. So there are commercial vendors available for HLA typing. As far as for inborn errors of immunity is concerned, I have already shown that it's a very complicated bioinformatic analysis for inborn errors of immunity. अभी मैं सर की फील्ड में jump in कर रहा हूँ, trespassing कर रहा हूँ. You can explain it better. But it's a whole teamwork of all the immunologists, the molecular biologists, the bioinformatician, and the data analyst. And finally, this is how they can finally regard some variant as variant of significance or uncertain significance, pathogenic. There are no commercial kits available for the diagnosis of inborn errors of immunity, but these laboratories offer the commercial panels. For Pakistan, this teamwork has to be collaborated by someone.
These things are available for at least 10 years. So what I was pointing to with your effort, a workable solution with the equipment and the reagents which are already on offer or available in the local market. They can import it easily and a workable solution. Obviously, we all know that there are these platforms, Illumina is most extensively used, and there are dedicated manufacturers for the tissue typing reagents. So actually, they have these sort of kits, and one of which was used by in your facility as well. So kind of pamphlet, a working solution, because you understand, you have gone through it, for the local laboratories, how one should go about it in the current scenario.
For those involved in transplantation, like for HLA typing, this is very easy. The workflow solutions that use the kits, there is no alternative method. Use the library collaboration kits and use the bioinformatics tools provided by the vendors themselves. There is no alternative to that, like in-house. But for inborn errors of immunity, there is a different approach for the diagnosis of inborn errors of immunity, as the target capture method is different.
This is
नहीं सर, inborn errors of immunity में सर कोई नहीं है हमारे साथ. Tissue typing में सर, these are the Illumina are the main vendors that provide the equipment. Sir,
नाम है specifics के साथ. ये solution may work in your sort of expertise area.
Sir, what kind of solution? Specify करें sir question. You are talking about the equipment. You are talking about the kit.
दोनों चीजें. एक workable solution.
Sir, there are different types of equipment available with all the vendors. This depends upon the workload a laboratory has. If a laboratory has less workload, then these can use a smaller sequencing instruments that can sequence about 10, 12 samples at a time. But there are higher throughput instruments that can sequence about hundreds of samples at a time. This depends upon the laboratory workload. जी आप सॉरी सर आप कुछ कह रहे थे.
मैं सिर्फ ये बताना चाहता कि इल्यूमिना 454 पाकिस्तान में वाहिद मैं लेके आया था. इल्यूमिना पाकिस्तान के साथ बिजनेस नहीं करता, कभी भी उनका कोई बंदा यहाँ नहीं आएगा. हमें सिंगापुर जाना पड़ा, वो इक्विपमेंट लाए, उनके केमिकल सिर्फ स्पेसिफिक हैं, वो केमिकल नहीं मिलते. इसका बेस्ट सॉल्यूशन ये है कि इल्यूमिना की आप सैंपल यहाँ से भेजें. आपने $1000 का, मैंने तो कल परसों $300-350 में ₹1,00,000 से $1.5 लाख का सैंपल भेजें और बेहतरीन एनालिसिस करा. दिस इज द ओनली वर्केबल सॉल्यूशन इन पाकिस्तान.
बस विद रेफरेंस टू पाकिस्तान का, पाकिस्तान में क्या सॉल्यूशन हो सकता है?
एक छोटा सा बस, I would like to know your take. Excellent presentation. जबरदस्त, बहुत सारा इसके अंदर information थी. One thing which you talked about, and we know the technicalities, the cost of doing this HLA typing. There is one school of thought, they stress on immunosuppression. They claim, there are data available, they claim that even if there is no match, even then a person can survive until, let's say, 10 years or so. So, what would you talk? What would be your comments on this immunosuppression, the success of immunosuppression? Because in foreign, as you know, that it's difficult to get the human organs. So basically,
but sir, definitely the success increases with the degree of HLA matching. If the HLA matched donor is available, he is preferred. It is preferable to have an HLA matched donor. But in the West, if the HLA match donors are not available, like there are not consanguineous marriages, are not donors available in the family, they have registries available where they can check for the donor availability and degree of matching, and they are able to find about maybe I think 6 or 7 by 10 match donors for most of their patients. So they have their own systems in place for increasing matching. Definitely, with the outcome increases with degree of matching.
So किसी ने
बचिया कुछ
publish किया है वो आपके 50 जो आपने किया 50 केसेस
जी जी
आपने उसकी मेथोडोलॉजी पब्लिश की है लोकली सही वो उसके रिजल्ट्स या
सर मैंने पूरी मेथोडोलॉजी शो की है
नहीं वो आपने की है ना लेकिन आपने की पब्लिश की है
पब्लिश हुई है जेसीपीएसपी में नीचे रेफरेंस दिया हुआ था सर वो जेसीपीएसपी में पब्लिश हुआ आर्टिकल 2020 में डॉक्टर बजिया कुछ पहले पूछे थे
actually सर की बात को कंटिन्यू करेगी because you have the expertise we would want to do हमारे पास जो वेंडर्स आते हैं कि किसी की है कब नहीं किसी की है तो we are very apprehensive हमें किस तरह स्टार्ट करना चाहिए नहीं करना चाहिए and then again कि आपके पास 24 पेशेंट्स हों फिर आप करें तो कॉस्ट बहुत बढ़ जाती है so we would अगर if you share your experience and किस तरह से आप कर रहे हैं तो that would be really helpful for us
आई थिंक अभी तो शायद मैं बेहतर बता सकता हूं अभी तो एफआईपी में नहीं हो रही शायद एनजीएस लेकिन इनिशियल प्रॉब्लम ये होता है क्योंकि इट इज एनजीएस इज पॉसिबल ओनली विद द बैच टेस्टिंग एट लीस्ट इफ यू हैव टू हैव 12 samples for doing the NGS so you have to complete 12 samples and it is possible for all the family like if there are 4 or 5 donors available they don't want HLA typing all to be done at the same time it multiplies the cost so it is actually very difficult to complete the batch. It takes time. Sometimes it may take up to like in our workload it could take 15 or 20 days for completing the batch and then doing the HLA typing. So ये time का issue होता है batch complete करने में. इसे reduce इस तरह कर सकते हैं कि कुछ flow cells होते हैं small capacity के जो काम करते हैं maybe I think they have a flow cell that can sequence up to 6 samples. So इससे कुछ main cost flow cell की होती है. So it can I think reduce the cost to some extent.
We like to do it, so we're going to contact you actually.
Most
Yeah,
welcome.
we don't really know how to go about it.
Thank you.
Thank you.
Free paper session. We will have 10 minutes each, including 8 minutes for presentation and 2 minutes for question and answers. So first, I would like to invite Ms. Sana Zainab, who will present on levels of C-reactive protein in cerebrospinal fluid of septic and aseptic meningitis patients. And she is from Exam Kidney and Liver Institute and Research Center.
Assalamualaikum. Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Sabri bismi rabbikal azim. So exalt the name of the Lord, the Most Great. La uqsimu biwaqin najum. Then I swear by the setting of the stars. And indeed, it is an oath if you could know Most Great. My topic of presentation is levels of C-reactive protein in cerebrospinal fluid of septic and aseptic meningitis patients. The contents of the presentations are objective, introduction, material and method, result, discussion, then conclusion. Objective of my presentation is to determine the frequency of elevated level of C-reactive protein in CSF of septic and aseptic meningitis patients. Introduction. Meningitis is a very common disease, especially in many developing countries, but the definite occurrence of meningitis is not known. Meningitis, inflammation of protective membranes covering the brain and spinal cord, known cumulatively as the meninges. Meningitis infection is caused by with viruses, bacteria, or other microorganisms. The inflammation can be caused by a bacterial infection known as bacterial meningitis, and when not caused by bacteria is known as aseptic meningitis. Meningitis is a major cause of mortality and morbidity in children in developing countries. The World Health Organization estimated about 1.2 million cases of bacterial meningitis are reported worldwide annually, and of those 135,000 result in death. Pathophysiology of meningitis. Out of several causes of meningitis, most studies pathogenesis of bacterial etiology. 3 types of bacteria involved in causing this disease: Haemophilus influenzae, Neisseria meningitis, and Streptococcus pneumoniae are common of them. The classic clinical trial of meningitis includes fever, headache, headache, rigidity, stiff neck. In meningitis, CNS infection starts when meningeal dilation takes place. Inflammatory cells, including lymphocytes, exactly targeting the infective agent. These cells amass in CNS and release the inflammatory cytokines such as IL-1 beta, IL-6, and tumor necrosis factor alpha. Then plasma cells increase local immunoglobulin production. These inflammatory responses leading to increased permeability of the blood-brain barrier. This allows the appearance of protein, including C-reactive protein, into CSF. What is the role of CRP? The serum C-reactive protein levels are measured on a routine basis for diagnosis and detection of many diseases. Normal concentration of CRP in healthy human serum is usually less than 6 mg per liter. However, higher levels of CRP is up to 10 to 40 mg are found in late pregnancy, mild inflammation, and viral infections. In cases of active inflammation and bacterial infection, it may go up to 40 to 200. The levels of CRP may be as high as up to greater than 200 mg per liter in cases of severe bacterial infection and burns. CRP levels in CSF. However, estimation of CRP in CSF not routinely done can possibly be a valuable highly diagnostic tool. Normally, CRP is not found in CSF. The CRP in CSF is raised in CNS infection like meningitis. The presence of CRP in CSF is indicator of damage to blood-brain barrier, which is destroyed by infection. Also, the levels of CRP in serum are found to be much more higher in bacterial meningitis as compared to viral meningitis. Material and method of this study is the cross-sectional study conducted in the Department of Diagnostic Immunology and Serology, Children's Hospital, Lahore, after getting approval from Ethical Review Committee and Advanced Study and Research Board of Children's Hospital. The sampling technique was consecutive non-probability sampling. 200 samples of CSF children were taken, out of them 100 of septic meningitis and 100 cases were of aseptic meningitis. Patients confirmed after CSF cytology, microbiology, and chemical analysis as septic meningitis and aseptic meningitis were included. The children up to age of 17 years were included. The data was handled and analyzed using SPSS 25. Qualitative variables such as clinical findings of meningitis frequency were calculated. For seeing association, Pearson chi-square test was applied. A p-value of less than 0.05 was considered as statistically significant. These are the results of study. As you can see, in septic group, 36% were females and 64% were male. And aseptic group, 62% were male and 38% were female. In this table, septic and meningitis level, CRP levels were compared with septic group and aseptic group. As you can see, in septic group, elevated CRP levels were found, while in aseptic group there was no patient lying in this category, and it was statistically significant. सिर्फ सेप्टिक ग्रुप के अंदर जो है वो स्टडीज भी यही कहती है, हमारी स्टडी में भी आ रहा था कि जो पेशेंट्स होते हैं उनके अंदर सीआरपी लेवल ज़्यादा
markedly elevated to compare not be mildly elevated.
Association between CRP and WBC, number of patients, as you can see, we categorize the WBC levels less than 100 and greater than 100. As you can see, most of the patients whose WBC levels are less than 100 are above than 80. And greater than 100 WBC level are around 50 patients lie in this category. Discussion. Whenever we carried a study on 26 patients, out of these 5 was bacterial meningitis, while remaining were of viral meningitis patients. This study shows that high levels of CRP were found in the CSF of bacterial meningitis patients as compared to viral meningitis patients. So it was concluded that CRP in CSF can be used as a rapid screening test for differentiating the bacterial meningitis from viral. It was proposed that negative CRP test rule out the bacterial meningitis. Kumar carried out the study. He took 15 bacterial meningitis and 10 non-bacterial meningitis patients. CSF CRP levels were significantly higher in bacterial meningitis as compared to non-bacterial. He concluded that CSF-CRP estimation is useful marker to differentiate bacterial meningitis from non-bacterial. However, it cannot differentiate between tuberculosis, fungal, and viral meningitis. Another study carried out by Ibrahim, Egypt, where the correlation between white blood cell and CRP was observed in CSF. There were 38 patients where it was observed that a positive correlation exists between white blood cells and CRP. Ivanko et al. Conducted a study in Kazakhstan. He took 269 patients. Out of this patient, 123 had bacterial and 146 had viral meningitis. Blood and CSF reported at a short significantly increased levels of CRP and procalcitonin in children with bacterial meningitis as compared to children of viral meningitis. Nathani in his study deduced that CSF-CRP is highly sensitive and specific marker for the diagnosis of bacterial meningitis. This study included 48 cases of septic and 35 patients having raised CSF-CRP level as compared to aseptic meningitis patients. 6 patients were found to have elevated CSF-CRP level out of 42 patients with viral meningitis. Conclusion of this study is CRP can be used not only as a diagnostic marker for septic meningitis but can be used as differential marker for septic and aseptic meningitis as well. The limitation of the study is small size and further investigation should be done by using molecular techniques like multiplex PCR on CSF for the detection of organisms and their mutations. Thank you.
The next presentation is by Dr. Sabiha Anis, a consultant immunologist and section head Indus Hospital in Health Network, and she will speak on intravenous immunoglobulins administration for immunodeficiency patients, the clinical audit at a tertiary care center.
Share this data of intravenous immunoglobulin administration in our patients with immunodeficiencies. So I have nothing to disclose. So this will be going to be the content of my talk. I'm going to talk about what is IVIG, its clinical utility, what are the issues associated with IVIG administration. I'll share some of our data and will conclude with some recommendations. So what is intravenous immunoglobulins? These are derived from food plasma from thousands of volunteer healthy donors, and it contains polyspecific IgG. The IVIG dosing depends upon its utility or for which purpose it's going to be administered, such as if it is going to be administered for the replacement, as a replacement therapy or as an immunomodulation. So for replacement therapy, low dose strategies is used at 300 to 800 milligram per kilogram of IVIG, given every 3 to 4 weeks in primary immunodeficiencies as well as in secondary immunodeficiencies. For immunomodulation, high dose strategies are adapted as 2 gram per kilogram divided on a few days, or 400 milligram per kilogram to be given on 5 consecutive days. And these are some FDA approved conditions for the immunomodulation therapy. So I'm focusing only on its utility in the primary immunodeficiency. So I'm going to talk about its mechanism of action as a replacement therapy. So we know that antibodies has 2 portions, FAB portion and FC portion. So with the FAB portion, it causes neutralization of the pathogens, inactivation of the toxins, opsonization, causes induction of the B cells proliferation and immunoglobulin synthesis, increase of CD4 T lymphocytes number, and increase of myeloid dendritic cell activation. And with the FC dependent activities, it causes activation of the phagocytic cells, complement activation, enhanced clearance of the microorganisms, as it is also shown in the diagram. But there are issues associated with the IVIG. Primarily, it is very, very costly, and in immunodeficiencies, it has to be given as a lifelong replacement therapy. And then there are side effects also associated with IVIGs. Some common side effects include headache, nausea, abdominal pain, myalgia, urticaria, chest discomfort, low-grade fever, and flushing. The major side effects include aseptic meningitis, acute renal failure, thromboembolism, myocardial infarction, anaphylaxis, and there are other side effects as well. So the patients who are on IVIG, they have to be really very strictly monitored, not only for the clinical outcomes, but also for the side effects. And one other very big issue is there is a worldwide shortage of IVIG. So the IVIG administration has to be rationalized accordingly. So the objectives of this analysis study was to determine the infection episodes and IgG trough levels post-IVIG, and to look at the side effects of the IVIG infusion. So it was a descriptive study, observational study. It was conducted at Indus Hospital Health Network. So, Immunology clinic was established in Indus Hospital in 2019, and since then we have catering 13 patients, and we are giving IVIG to them. So we have included the data of all those patients. It starts with the diagnostic workup, thorough history, physical examination, CBC with peripheral film, viral markers, radiology, serum immunoglobulins response to test vaccination, complement levels, lymphocyte subsets, and inflammatory and autoimmune markers if indicated. The data was entered on SPSS version 21 and analyzed for the age at presentation, the time to refer to the immunology clinic, probable diagnosis, initial and subsequent clinical condition, number of infections, severity, and immunoglobulin levels, and other immunoglobulins and lymphocyte subsets. All patients that received gamma RAS, which is 5% IVIG, and adequate IgG trough levels considered at 5 grams per liter. So these are the results. The patients at the age at the presentation was it ranged from 1 to 396 months with a median of 48 months, and there were 5 adults and 8 children. 10 were males and 3 were females. The clinical features included recurrent chest infections, fever, upper respiratory infections, recurrent diarrhea, ear infections, bronchitis or autoimmunity were in 2 patients, and there was a skin rash and infection in 1 patient. So the most common diagnosis in these patients were antibody deficiency with in 11, and 6 patients with CBID, and 5 were with gammaglobulinemia. In 1 patient, there was hyper IG, and 1 remained uncharacterized or undifferentiated. So median duration of the referral to immunology clinic from other clinics were 4 weeks, ranging from 1 to 400 weeks, and there were 3 direct referrals from other centers they were referred to. Median time taken for initiation of the IVIG from initial presentation was 21 days. Initial immunoglobulin levels were low to absent in 10 patients. IgA level was absent in or low in 9 patients. IgM was absent in 4. IgE were absent in 4 and high in 1. And the lymphocyte subset analysis showed low to absent B cells in 8 patients, and 1 of the patients also had low NK cells. Genetic analysis was available for 4 patients, and 2 had BTK mutations, 1 had ILB, and in 1 it remained inconclusive. So we looked at the response to IVIG therapy. The clinical improvement with decreased incidence of the infections initially was seen in all patients. In 8 patients there was marked improvement, and 5 patients there was an improvement with less number of infections and less severity for the infections. But in subsequent visits, the infection episodes, we found that in some of the patients, that after improving, the infection episodes have recurred. So we looked at the IgG trough levels, and it was adequate in 4 patients, and it was inadequate in 6 patients. The reasons included of these problems were non-compliance in 3 patients, IVIG non-availability at the time when they were requiring or the IVIG administration was due. And then in one of the patients, it was community-acquired infections. The 9 of the patients, they had 1 or more than 1 reaction to IVIG, and 2 of them had more than 1. And the issues identified were with the IVIG lot and then rapid infusion rate. But none of them suffered life-threatening reaction. There were 4 patients who were lost to follow-up, and 2 of these patients are actually non-compliant. They are lost to follow for some months, and then when they become very sick, they come again into the opinion. So I conclude by saying that IVIG improves the quality of life in patients with immunodeficiency. Non-compliance and non-availability of IVIG are the main issues that affect efficacy endpoints. Delayed referral in some patients indicates that there is a need to spread awareness for immunodeficiency disease, as in early intervention is the goal. There is a dire need to locally manufactured IVIG, and availability of subcutaneous IgG with home facilitation is another way forward that may also help to reduce non-compliance. Thank you. Any questions?
The house is open for questions.
Yes, sir.
Thank you very much. Very interesting talk. Just a query, because you have got a set of patients, how could you homogenize those presenting complaints or basic defects? Like 2 of them, if I remember, have got BTK deficiency or mutation.
Yes.
So, as far as I remember, there is more than 400 mutations documented in BTK gene. So, isn't it that, and few of them have got CVID, the patients.
Most of the patients had CVID.
So, my concern is that depending upon the reason of this immunodeficiency, at the end of the day, the symptoms which they develop, as we say, complications or repeated infections. So, isn't it that because, let's say, if the patient has got BTK mutation, he or she will be having more likely to have complications as compared to CVID, and so on.
Supplementary question. So it's a standard practice to have an infection diary so that you can put numbers, points, infection diary for whole month, how many episodes of infection, what days of antibiotics, what days of school missed or activity missed, what was CBC like, neutrophilia and CRP and other things. And then you have, you match it against infusion diary. So the question that you must have a baseline for an individual patient. So many infections, and that was the dose decided. And what happened after the 2 months use, 3 months use? How did you modify for that patient? And this would be different for each type of patient. In say A gamma, it may be different. For CVID, it may be different. And for hyper IgE, if you have used it, it would be different. So giving a numerical value to those infection diary points, and then you have infusion diary points, and then you compare these numbers with each other. This was the kind of percentage improvement. You could use minimal of IVIG for those patients, and for others you require more of it and more often. So he's just asking that they were not having the same
but
disease.
I've just put in the cumulative effect of all the patients. I have not
The emphasis should have been infection and infusion.
Maybe I should have put in the tabular form that this patient 1, 2, 3, 4, and this was the initial infection rate, but I didn't do that because I didn't know how much time I should be infected.
Cost पर भी जरा क्वेश्चन डालो.
Cost का तो मसला है सारा. So actually in this hospital we are providing free of cost these IVIGs. And one vial cost for gamma ras is costing us 25,000 per vial. And so as the dose increases, naturally the cost increases. So if we are not going to give them, they will lost to follow up anyway. But we are giving them free of cost. Still then some of the patients are.
चाइनीज नहीं होते IVIG?
वही चाइनीज
मतलब वो और महंगे हैं और कॉस्टली हैं.
बाकी तो और महंगे ना. ज़्यादातर gamma ray से जो लीगली यहाँ पे आ रही है, बाकी जो है वो मेरे ख्याल से लीगली नहीं आ रही है और they are more costly.
Chinese जो है वो तो लीगल import.
वो लीगल नहीं. Gamma ray is legal import. बाकी जो है पेंटाग्लोबिन और वो सारी लीगल.
Gamma ray किसकी है? Gamma ray तो Chinese है ना?
Chinese है.
ये भी
ये Chinese है. और इसके साथ इश्यूज हुए थे पिछले लॉट प्रॉब्लम आ गया था सिलेक्शन हो गया
और कुछ है नहीं.
अभी तो कुछ नहीं है. मगर सही भी कर लिया इन लोगों ने. तो बाकी हम क्योंकि ये भी एक मसला होता है कि जब हम IVIG दे रहे होते हैं जो हमारा जो क्लिनिकल वहाँ पे जो नर्सिंग स्टाफ होता है उनको बस समझाना होता है बिकॉज वो जल्दी करने की कोशिश के अंदर फ्लैशन IVIG के अंदर हम लोग को बहुत इसके अंदर रिकॉर्ड करना पड़ता है कि उनकी रिएक्शन लॉट की वजह से हो रहा है या बिकॉज ऑफ एडमिनिस्ट्रेशन. और फिर उस वजह से भी अगर लोगों को जब रिएक्शन होता है तो दे डोंट कम अप अगेन फॉर IVIG कोई डर जाते हैं. ये सारी मसले हैं. थैंक यू.
Of asthma exacerbations with paper mulberry, pollen in Islamabad, and observational study by Dr. Usman Yusuf. Dr. Usman Yusuf is a consultant physician and allergist at the Allergy and Asthma Institute in Pakistan. He has over 20 years of experience in the field of allergy and asthma and is a leading expert in the region. He is a fellow of the Royal College of Physicians of Edinburgh and Glasgow and is a member of the British Society for Allergy and Clinical Immunology. He is also a member of the Pakistan Medical Association and lifetime member of Pakistan Society for Immunology.
To all of you. This is going to be a very boring presentation because this has sorry, big boss at the back. This is going to be a very boring presentation because it has statistics or so. I thought कि किसी को पसंद नहीं आएगी, but still. Essentially, Islamabad में जैसे आप सबको शायद पता हो, Islamabad became very popular over the last 30 years के मौसम बहार में जहाँ इतने खूबसूरत वो शहर है, लोग अस्पतालों में पहुँच जाते थे और emergencies भर जाती थी, लोगों की deaths भी हुई हैं, and Islamabad got the name of the capital of allergy, pollen allergy in the world. But no one had any scientific proof कि हो क्यों रहा है. There were speculations. And when we looked at data, we found that in March, we saw this yellow line, a peak of new patients year after year after year coming in March. So this needed a scientific investigation into why this was happening. So with this background, although it's known throughout the world that pollen allergy and pollen asthma is well recognized, लेकिन ये जो पेपर मलबरी जिसको हम इम्प्लिकेट कर रहे थे, जंगली शहतूत जिसको कहते हैं, ब्रोसिनेशिया पेपरिफेरा, is this really the cause? या बस ये हो सकता है कि उसी वक्त कोई और भी चीजें हों और अनासर हों which might be causing the same symptoms, and this is why we set out to try and investigate this scientifically. What we looked at was our retrospective analysis. We looked at our records over the last 20 years. We looked at patients. Then we counted, we had teams in place at the Pakistan Institute of Medical Sciences in Islamabad, जो कि 24 घंटे 8-8 घंटे की शिफ्ट से वो मुतवातिर पूरा पीरियड फ्रॉम मार्च 2020 till July 2021 रोजाना वो मॉनिटर कर रहे थे कि कितने लोगों को नेबुलाइजेशन हो रही है for status asthmaticus. And we took a cohort of patients, some sensitized, some non-sensitized. I've talked about them. और उनको सबको peak flow meters दे दिए गए कि आपने सुबह उठते साथ अपनी peak expiratory flow readings लेनी है, उसके बाद bronchodilatory inhaler लेना है और उसके बाद दोबारा से readings लेनी है. And this they did for 17 months. So we got all the data out of the samples that we looked at. Over 1,000 patients, we calculating with 95% confidence interval, we calculated we needed 284 patients. So हमने 284 select कर दिए. What did we find out? We looked at कि क्या उनको past में इस तरह की history क्या थी? Patient ने कब कहा कि मुझे asthma exacerbations हुई हैं? And what did the physician actually document? बहुत दफा होता है patient कहता है जी मेरी तबीयत बहुत खराब है, मुझे सांस नहीं आ रहा. But actually, when a physician examines him, he's perfectly okay. When we looked at the nebulizations in bins, we found that from 1st March 20 to July 21, we had a large number of nebulizations, but unfortunately, उसी वक्त में COVID भी आ गया. So we had to see whether it was COVID or not. And regarding the people given peak flows, we selected asthmatics and non-asthmatics, और asthmatics में हमने those sensitized to paper mulberry and those not sensitized to paper mulberry, and the same thing with non-asthmatics. When we looked at the pollen data collected over the years, we found that March was the period when we had the maximum amount of paper mulberry pollen being released into the atmosphere. So हमने अपनी स्टडी को सिर्फ मार्च के महीने पे फोकस कर दिया. जो 946 से almost 1,000 patients हमें मिले थे, these are the data, they're all published. We found that out of these, approximately 41% were sensitized to paper mulberry pollen, while about only 5.8% were not. And this is data that we'll look at later. हमने asthma को देखा, उन लोगों में 85% patients को they had increased asthma symptoms in March. Acute asthma events, almost 30% ended up in emergencies for some reason or the other, या उनको steroids की जरूरत पड़ी. और patients ने 1/5 उनमें से confirm किया that yes, this is an exacerbation. When we looked at correlation of asthma exacerbation with pollen counts, because the pollen counts are very erratic and we had other data, we normalized it from 0 to 1. और उसमें हमने देखा in the first graph on the left, and I don't know if this, yes, it does show. So these are the pollen counts. As you can see, paper mulberry pollen March में एक बहुत बड़ी peak आती है. And we see कि जिन लोगों को asthma exacerbations हैं, वो भी मार्च में बढ़ रहे हैं. And during our study period, भी मार्च में वो emergencies में पहुंच गए. And the physician confirmed that which you see in the fourth graph. जो non-sensitized थे, उनमें again same pollen peak, same everything, and you can see in all the three graphs there is no exacerbation, कोई asthma increase नहीं हुआ. जहाँ तक nebulizations का जिस वक्त देखा गया, तो I'm just going to skip because for time. The nebulizations are in the blue. Nebulizations हमने देखा that they peak in March and again they peak in March. लेकिन बीच में nebulizations जो है वो December में भी peak कर रही हैं and COVID cases. They are peaking at 3 times in the year. Twice a year in spring and in winter. COVID तो बढ़ रहा है. Excuse me. लेकिन nebulizations आप देखें, those increase only in the peaks of the pollen season, and that goes along with the pollen counts. So when you look at these, you find that you have patients coming in who need nebulizations. Oh, thank you very much. Who need nebulization as the pollen counts go up. Dr. Sabiha हमेशा मेरी जान बचाती है. I'm going to skip a lot of things. When we looked at the peak flows and correlated them with pollen counts, हमने ये देखा in the first कि जो pollen counts increase हो रहे थे, patients की जो median peak flow readings हैं वो नीचे आती जा रही हैं, which means they're having asthmatic episodes. In the second one, which are non-sensitized asthmatics, उनको मौसम बहार में कोई फर्क नहीं पड़ा. लेकिन जो तीसरी चीज हमें पता चली, which was very surprising for us, and that is कि जो non-asthmatics थे, but sensitized to paper mulberry, उनकी भी peak flow कम हो रही है. अब हालांकि वो asthmatics नहीं है, क्योंकि उनकी सांस की नाली जो है वो तंग होती जा रही है. So obviously there is more to this which needs to be investigated. And on that basis, we can confirm that yes, increasing counts of paper mulberry pollen are responsible for increasing asthma. And because of that, you need health strategies, और इसको हम आगे लेके चल रहे हैं, and we are now looking at predicting the pollen seasons. We have developed an algorithm जो कि 3 दिन पहले बता देता है कि कब pollen की peak आएगी और patients को inform किया जाए ताकि they can take their medication. This paper has already been published 2 months ago, and this is the reference. Thank you all very, very much.
Second topic आपकी है, तो हम question answer पे दोनों topic बात करेंगे.
उस्मान, इसमें फ्लो रेट कम हुआ तो ये एस्थमेटिक हो गया ना, नॉन एस्थमेटिक हैं वो फिर एस्थमेटिक हो गए.
So that is actually the whole concept of allergic rhinitis and its impact on asthma.
Kind of predicting clinical diagnosis here, जो इसकी utility.
So what that would mean in the long term, ऐसे patients को आप preventative inhalers भी शुरू कराएंगे, even though they have no history, because it means they probably will become asthmatic. ये जो पूरा आर्या प्रोग्राम है, जैसे जीना है अस्थमा का, COPD है, COPD का गोल्ड है, आर्या is allergic rhinitis and its impact on asthma, and that is focused on this entire concept of one airway, one disease. वो एक नया चीज़ है, किसी और दिन बात करेंगे उस पे.
ये question.
10 पूछिए. You are the boss.
ये आपने जो उसको बताया कि कोविड सीजन के अंदर का डेटा है, जब कोविड भी चल रहा था ड्यूरिंग दैट, तो क्या वो उसका भी इम्पैक्ट इसमें शामिल है उन पेशेंट्स के ऊपर जो सेंसिटाइज्ड थे? Some of the patients might have gotten COVID and or you have excluded those patients.
That was our biggest question. कि क्या वो पेशेंट्स जो नेबुलाइज कराने आ रहे हैं आधे कोविड पेशेंट्स और आधे पेपर मलबरी पेशेंट्स. That is why the graphs show कि कोविड में नेबुलाइजेशन इंक्रीज नहीं हुई. इंक्रीज हुई तो सिर्फ पेपर मलबरी के मौसम में.
तो आपने उनको एक्सक्लूड कर दिया था उन पेशेंट्स
तो कोविड को एक्सक्लूड कर दिया. So the data that we calculated was minus COVID. तो वो एक किया और दूसरा कोविड की वजह से हमारी डेटा कलेक्शन में गैप्स आए थे. 4 महीने ऐसे थे कि बिन्स उन्होंने बंद कर दिया था बिकॉज ऑफ कोविड. सो हमारे डेटा वाज शॉर्ट. 17 महीने में से
15-20 साल की तो ये है सीरीज महाभारत का कम से कम ये मार्च वाला है.
तो अगर कोई पब्लिश डेटा नहीं है ना कि इज इट पेपर मलबरी फंगस भी तो हो सकता है. जी बॉस.
ये होता ही इतना ज़्यादा है ना. वो तो काउंट्स आ रहे होते हैं. वो तो सीडीए काउंट्स दे रहा होता है अप्रैल मार्च अप्रैल बहुत ज़्यादा है.
टेरिबल. और वो बढ़ता जा रहा है. बीच में बात करें एक सेकंड में प्रोफेसर नदीम साहब.
सर बस मैं थोड़ा सा ये पूछना चाह रहा था कि आपका जो मेजॉरिटी ऑफ द डाटा था पेपर मलबरी और बाकी जो भी एलेर्जेंस थे वो इस्लामाबाद बेस्ड बेसिकली डाटा है.
प्योरली इस्लामाबाद.
ओके. तो जिस तरह हम ये लिख रहे हैं कि एन ऑब्जर्वेशनल रिपोर्ट ऑफ एलर्जेंस इन पाकिस्तान, तो shouldn't we write it?
No, this is the next presentation.
Okay,
Sorry.
okay.
Sorry.
Thank you.
That was Islamabad. That is specific for
ठीक हो
Islamabad.
गया.
So just a very small question. Do you have any clinical correlate for this, like IgE level or something? I mean, showing with your increased nebulization and other stuff. Do you have any clinical correlate as well?
Dr. Sabha, IgE is, sorry for saying that, quite a useless test. ठीक है. Unless you are doing specific IgE for paper mlb. ठीक. Patients who are very severely allergic will have a normal IgE. क्योंकि जब एक कंपोनेंट IgE का स्पेसिफिक का इंक्रीज भी होता है ना, it's not enough to push up the whole IgE. Conversely, अगर कोई worm infestation हो, उसमें इतनी massive IgE राइज होगी या एक्जिमा में राइज होगी, जो कि स्पेसिफिक IgE में आपको वो नहीं नजर आती. So we didn't waste time on that. But if you took out serum samples from these patients and did specific IgE, it would be positive. I mean, that has been tested over the years, तो हमें उसको दोबारा करने की जरूरत नहीं.
सरोगेट आप स्किन टेस्ट करते हैं.
Skin test तो है, and all of these are skin test proven patients इनको हमने sensitized जो सारा था, they were sensitized to paper mulberry. मैं सिर्फ paper mulberry का डेटा था इसमें.
But there are other allergens as well. Circulating.
This talk.
Yes, sir.
प्रोफेसर ताहिर अजीज अहमद साहब लाइफ टाइम अवार्ड होल्डर ने हुक्म फरमाया था to compare the clinics in Islamabad, Lahore and Karachi. And this talk is dedicated to him and to Professor Sabiha जिनको बहुत शौक है एलर्जी टेस्टिंग करने का. And the whole purpose of this talk is not anything clinical, but to show you the allergens जो कि हम पाकिस्तान में देखते आए हैं over the last now 30 years of practice. और इनकी सिग्निफिकेंस, क्योंकि जब आप उनको देखेंगे तो देन यू रियलाइज कि वो क्या थे. आई हैव नॉट पुट इन नंबर्स, आई हैव नॉट पुट इन एनी क्लिनिकल डेटा. दीज आर ऑल स्लाइड्स व्हिच वी हैव टेकन फ्रॉम आवर वर्क. इफ यू वैक्यूम क्लीन दिस कारपेट हियर, या अपनी मैट्रेस को आप वैक्यूम करें और डाइसेक्टिंग माइक्रोस्कोप के नीचे देखेंगे तो दिस इज व्हाट यू विल सी इन द बेड स्लीपिंग विथ यू एट नाइट. House dust mites, Dermatophagoides species. Typical लोगों को सुबह उठते साथ छींकें आती, रात को 1 और 3 बजे के दरमियान दमे के अटैक होते हैं, कभी कभी खारिश होती है. छोटे छोटे बच्चे जो हैं वो रात को खांसते खांसते वॉमिट करते हैं. कोई डॉक्टर एस्थमा डायग्नोज नहीं करता, कोई एलर्जी नहीं डायग्नोज करता, उनको एंटीबायोटिक्स दे दे के सत्यानाश किया जाता है. This is the commonest allergen in Pakistan, found in over 87% of the people. I would say more than 10,000 people tested over the last 30 years. This is what you will see on a closer microscope. The second, very common, is this green color. I'm sorry, इसमें green नजर नहीं आ रहा, काला लग रहा है. लेकिन आप अगर अपनी ब्रेड बाहर छोड़ देते हैं, this is Alternaria tenuis. Alternaria alternata भी कहा जाता है. This is a very potent fungus. This and Aspergillus niger जो काले रंग का फंगस है, बड़ी टिपिकल हिस्ट्री है कि पुरानी अलमारी खोली या पुराने कपड़ों वाली अलमारी खोली जिसके अंदर फंगस था, या नमी वाले वॉशरूम में गए, सांस खराब होना शुरू हो जाता है। These are very potent allergens and these can kill. ये इतना सिवियर एस्थमा अटैक कर सकते हैं, पेशेंट की डेथ इसमें हो सकती है। क्लेडोस्पोरम हेर्बेरियम, ये भी आप देखें, if you leave a piece of roti outside you will see this growing up. Our good friend, आजकल तो अमेरिकनों का बड़ा बोलबाला है, but American cockroach and German cockroach, they shed large amounts of chitin and protein molecules even if they just cross your floor. और उसके साथ इतना ज़्यादा एस्थमा पाकिस्तान में है कि it's very very difficult to eliminate this. The famous paper mulberry का और भी जितने दरख्तों के तूत होते हैं, तूत जिसे कहते हैं, एक एक तूत पे तकरीबन 10 लाख छोटे छोटे फूल होते हैं, और ये अपना पॉलन जब शेड करते हैं तो इतना ज़्यादा होता है कि एक बादल की सूरत में ये नज़र आता है। और ये इसलिए शेड होता है कि नरीना मेल प्लांट से ये फीमेल प्लांट के स्टिकी पॉट्स में जाता है, और वहाँ से when it gets fertilized it becomes the fruit. This is the thing, the mechanism of how trees pollinate, जिनके फूल आपको नजर नहीं आएंगे, and this is why हजरत इंसान जब बीच में सांस लेता है वहाँ पे वो फंस जाता है। जंगली भांग, उसके छोटे छोटे पॉट्स हैं। This is the second major allergen in north of Pakistan, and north of Pakistan means from Sakkar all the way up to the northern areas. आप में से जिन हजरात को इसके पत्तों से शौक है वो आपको पता है, थोड़ा सा दूध में भी आप घोल के पी सकते हैं, इसके भांग के पकौड़े भी खा सकते हैं, उसका नशा कुछ और है, कनाडा में लीगलाइज हो गया, यहाँ नहीं हुआ। Common grass. This is the commonest allergen which you will find in Karachi and humid areas. American grass इसको कहा जाता है Sanodon dactylon, and you can see it has little pods, and these pods have seeds, और इसके seeds हवा में उड़ते हैं। लेकिन नमी के मौसम में इनके ऊपर फंगस लग जाता है, और इस फंगस को, इसी चीज के ऊपर फंगस लगता है, दिस इज कॉल्ड ओस्टिलागम, फंगस को कहते हैं। और कराची में अगस्त के महीने में जो नमी के साथ लोगों के सांस के अटैक होते हैं, दैट इज कॉज्ड बिकॉज ऑफ फंगस ऑन ग्रास। और लोग कहते हैं जी नमी की वजह से मुझे अस्थमा हो रहा है, दैट्स नॉट द रीजन, दिस इज बेसिकली द रीजन। We are a cotton producing country. Cotton spinning, cotton ginning, cotton harvesting, sticky dust is a very major issue. We are a wheat producing country, so wheat की threshing जिस वक्त होती है उसके साथ जो जितना उसकी dust generate होती है, that's an issue. चावल की husking, ये हमारे यहाँ काला शाह काकू के पास की तस्वीर है, ये सारी वो environmental dusts हैं जो हमारे यहाँ मुख्तलिफ seasons में होती हैं। So if you want to do an allergy practice in Pakistan, you should know कि आपके शहर में बैठे हैं और आपके शहर के गिर्द क्या क्या allergens हैं और आपके patients कहाँ से आ रहे हैं। I'm sorry, this is a slide taken from the internet. ये दालें साफ हो रही हैं इस वक्त नवंबर में, सिंध में, इंटीरियर सिंध में दालों की मिलिंग का सीजन है। हैदराबाद, सखर, सांगर, शाहदादपुर उस साइड पे इस वक्त इतना ज्यादा ये हवा में डस्ट है इसकी, it's causing asthma as bad as the threshing season in north of Pakistan. इसी में फंगस में फिर स्टोरेज माइट्स भी आ जाते हैं। इनकी और हाउस डस्ट माइट की इतनी क्रॉस रिएक्टिविटी है कि हमने इसके ऊपर ज्यादा we didn't spend much time or money on this. Our beloved कीकरी की झाड़ियाँ, कराची आप शारे फैसल पे आ जाएं, पूरे this is behind the Karachi University, Prosopis juliflora, इसके छोटे छोटे उसी तरह के दूध होते हैं। डॉक्टर सबिया किस तरह मुस्कुरा रही हैं देख देख के, उनके पता की इंटरेस्ट के पीछे भी होते हैं। एंड दिस इज अ मेजर कॉज अगेन ऑफ एलर्जी इन अगस्त, जिस वक्त ये खिलेगा एंड इट गोज ऑन टिल सितंबर। ग्लोबल चेंजिंग की वजह से भी फर्क पड़ रहा है। अदर दिस इज मगवट, रैगवीड, ये आम झाड़ियां हैं जो कि हमारे सड़कों के किनारे लगी होती हैं, but these are very strong allergens, हम इन पे तवज्जो नहीं देते। रैबिट ब्रश, लाहौर, सियालकोट, सरगोदा, इस साइड पे फैसलाबाद, ये बहुत बड़ा मेजर एलर्जन है। Before I close, I'm just going to point out 2 or 3 different things. पाकिस्तान में गुज़श्ता 120 सालों में हमारा जो एवरेज टेम्परेचर है that is gone from 50 सेंटीग्रेड माइनस से लेके अब 50+ पे हम चले गए। Global warming over the last 100 years has affected Pakistan very badly. And Pakistan, as you all know, because of our floods, is one of the worst hit countries in the world. इसका क्या मकसद है? इसका मकसद ये है कि अगर आप पोलन पीक्स देखें, पेपर मलबरी पोलन की है, 2019 में ये पीक 26 मार्च को शुरू हुई। 2020 में बारिशें हो गई, पीक नहीं आई। 21 में ये 16 मार्च पे आ गई, 22 में भी 16 मार्च, और अब 2023 में 16 मार्च से पीछे आके ये 11 मार्च पे आ गई है। So every year it's coming earlier and earlier and earlier. This is what's creating problems. Patients are not ready to face the allergy. And the other thing is, if you compare 2022 with 2023, the peak is now more sustained and higher. So it means more patients are going to suffer, more load on the hospitals, more possibility of deaths, and more need for us to do something about this. And this is where I'd like to close. Thank you all very much.
Thank you very much. What would you say the most frequent allergen for say summers and for winters for Islamabad and then for Lahore and then for Karachi? If you have to pick one.
House dust mite 87% throughout Pakistan all around the year. उसमें फर्क सिर्फ ये पड़ता है कि ठंडी हवा जब हो जाती है तो उसके सिम्टम्स एग्रीवेट हो जाते हैं, बट as an allergen that is above anything else.
आप रहते हैं ना तो ज़्यादा दिन उड़ते रहते हैं,
उससे
उसमें ज़्यादा हो जाता है ना,
खिड़कियां दरवाजे बंद हो जाते हैं।
Accepted throughout the year.
बहुत
ये सीजनल जो है ना, ये गर्मी का और सर्दी का,
वो तो फिर जगह के हिसाब से चेंज
लाहौर में क्या है?
लाहौर में is basically again depends on where in Lahore. ठोकर न्याज बेग साइड पे रिंग रोड वो सारी थ्रेशिंग एरियाज हैं, ये मेरे लाहौर के बादशाह बैठते हैं, DHA ये सारी साइड. If you go into inner Lahore, it's house dust mite. पेपर मलबरी ये जो है ये 1852 में लाहौर में सबसे पहले पाया गया था, इस्लामाबाद में तो अब आया है. This was a major allergen all down the नहर, और फिर अल्लाह भला करे शहबाज शरीफ की जब पहली हुकूमत आई उन्होंने सारे दरख्त काटे थे to widen jail road. I'm sure those of you who live in Lahore will remember कि वो पेट्रोल पंप्स बनने से पहले वहाँ दरख्त ही दरख्त हुआ करते थे. पेपर मलबरी was a major allergen in Lahore, but लोगों को पता ही नहीं था.
और
कराची में इस ग्रास का जो फंगस है, ब्लैक कीकरी, और कीकरी की जो है वो ज्यादा अफेक्ट कर रही है. गुलशन जौहर में अब कम हो गए, गुलशन इकबाल में, शारा फैसल, बट वंस यू क्रॉस PCHS वहाँ कीकरी जो है उसकी वो कम होती जाती है. आपको याद होगा कराची खैर पता नहीं मुझे बड़े छोटे.
What about dust in Lahore? Dust. Isn't it a big factor?
You know the world's most polluted city. Dust, yes. Dust, yes, because the types of dust are very different. You see, the dust leads to smog, and the smog is a different issue altogether. So coming back to Karachi, you remember Karachi, second south, Sunset Boulevard was the end of Karachi. उसके बाद समंदर शुरू होता था. जो वो उसको रिक्लेम करते गए तो उनको प्लांटेशन करनी पड़ी, उस प्लांटेशन पे अपना पोलन आना शुरू हो गया. So there are different types of pollen seasonal in phase 8 से लेके phase 13 तक वो सारे. So Karachi is area wise. So Lahore में चले जाएं वहाँ पोलन ही नहीं है. I'm sorry. जी डॉक्टर.
कराची में बस एक चीज और ऐड कर दूं कि जो मेजर एलर्जी इस वक्त हो रही है ना जो लोगों को, वो पेशेंट्स हो रही है. वहाँ जो है वो कबूतर हर जगह है, एवरीवेयर. और कराची में एक ये भी प्रॉब्लम है कि फ्लैट्स में लोग रहते हैं और वहाँ से आप कबूतरों को भगा नहीं सकते. सो उस पे आपका कोई है कि कौन सी प्रोटीन है, क्या है जिससे लोग.
This is interesting इसके ऊपर.
जी बहुत.
हम तो लाहौर में करते हैं, लाहौर के हमने पिजन, क्योंकि लाहौर में लोगों ने घरों की छतों पे रखे होते हैं.
नहीं हमारे रखे नहीं, हमारे यहाँ वहाँ
आपके
पर
अंदर आते हैं, I know वो अपार्टमेंट्स पे आके बैठे होते हैं सारे.
नहीं कराची में लोगों को बाजरा डालने का बहुत शौक है. हर चौरंगी में वो बाजरा डालेंगे, सदके का या जो भी.
ये है प्रॉब्लम। और वहाँ वो उनकी ब्रीडिंग हुए चली जा रही है और वो जो जॉइनिया हैं या वो हैं, वो उनके इर्द गिर्द जो फ्लैट है उनमें जो रेजिडेंट्स हैं, दे आर सफरिंग फ्रॉम एलर्जी।
डॉक्टर साहब, मैं आपको एक्सट्रैक्ट भेजता हूँ 100 लोगों को स्किन टेस्ट करना।
जी आप
तो हमारे पास डेटा तो आए ना।
जी
ओके डॉक्टर उस्मान, सो थैंक यू सो मच। हम लोग इसको डिस्कस करते चले जाएंगे, लॉट ऑफ डिस्कशन इज जनरेटेड, so we'll be concluding the session, but before that Dr. Umair has announced.
We'll have the annual general meeting session of our Society for Immunology right after this conclusion of the session. So we'll request all the esteemed participants to stay.
Thank you, Mayor. So this was a very interesting session. We had 3 very enlightened invited talks by Dr. Sinessa, who actually demonstrated that how important genetic testing is in primary immunodeficiency disorders, and in fact he elaborated on the track, which I think we should be looking forward to, that we should be starting here soon in Pakistan also. And then we had a talk by Dr. Masroor Babar, and it was a very nice talk on the genomic editing, and some interesting facts came out of it and some interesting discussions came out of it. Then the informative talk by Colonel Hamid Nawaz Tibu about the NGS in HLA typing and in immunodeficiency disorders, and I hope that will help us to establish these facilities out here with your experience. And then Sana Zainab talked about the level of C-reactive protein and demonstrated that it can be used to differentiate between septic and aseptic meningitis. And then we had a very collaborative, very interesting, enjoyable talk by Professor Usman. So thank you very much, all of you. I hope you enjoyed the session. Now over to Dr. Umair.
Madam, for concluding the session, now we have come to end of this session, and before that we have to distribute shields and certificates, and for that I would request Professor Dr. Tahir Aziz to come up the stage and distribute shields and certificates. Thank you. So first shields is for chair of the session, Professor Dr. Sabiha Anis. Next is a shield for co-chair, Lieutenant Colonel Dr. Umair.
Okay, sir. Thank you.
Now, our next shield is for Dr. Masood Ilahi Babar Sahab. Now I would like to call Lieutenant Colonel Hamid Nawaz Tipu to receive his certificate and shield. Now the certificates for oral presenters. First, Ms. Sana Zainab. Now I would like to request Dr. Muhammad Usman Yusuf Sahab to receive his certificates. And now,
now for the moderator of the session, sir, the last sheet for the moderator of the session, Dr. Fahim Shahzad.
I would like to request my mentor, Professor Nadeem, to also come up on stage.
Thank you, everyone.
So now it is time for AGM.
May I have your attention, please? Now we will have the annual general meeting of the Pakistan Society for Immunology. Initially, a review of proceedings of the last annual general meeting. It was attended by 10 members, and the proceedings included the minutes of the previous meeting were endorsed by Professor Rabia, Dr. Najia, and Dr. Talab. Dr. Sabiha gave the report on her 2 tenures as General Secretary, in which she shared the achievements, member status, in the first PSI newsletter. Dr. Wajiha gave Finance Secretary's report on behalf of Dr. Khabar, and Professor Rabia acknowledged the efforts of Dr. Sabiha and congratulated her on the achievements, and shields were distributed to the lifetime members. Regarding the annual general meeting 2023, I will present the agenda items on the General Secretary's report, followed by the presentation of the Finance Secretary's report. As an overview, last year we had 53 listed members, and we have 5 new membership applicants in varying processes, at varying levels of processing, and we have total of 58 listed members at the moment. These are some of the agenda points. We finalized these agenda points in coordination with the President, who will be a little late and will not be able to join the proceedings today. So the first issue is related to the fundraising for PSI. The current financial state of PSI is not satisfactory. We have around 200,000 funds. The detailed report will be presented by the Finance Secretary. There's no source of regular funds except membership dues, and this does not allow us the necessary flexibility to plan any major events or finance international delegates. So this is just an overview of some of the recurring expenses. For example, $150 per year is expended on website maintenance. The IUIS annual fees varies from $50 to $100 per year, and there are miscellaneous expenses of $25,000, such as getting the shields made. So this is approximately $100,000 per year, which we need to raise. In the initial meeting among the council, we have this proposal that we can create our partners page on the PSI website and invite vendors to advertise their products. This particular model has been utilized by other societies. The advertisement tariff, just as an example, could be listed on the lines of platinum, gold, and silver options, where the vendors can pay for 150,000, 100,000, and 50,000 per year, and we can provide them one A4 sized content page on the website under the heading Our Partners, where they can get their page composed, and we will let that remain on the website for that particular year for which they pay. So this is one of the proposed models, and if there are any other proposed models, we are open to suggestion, because we need to do something about these funds. If we have to be flexible about arranging events.
अच्छी proposal, nice suggestion. इसमें ये है कि आपकी जो भी कोई एक मैनेजमेंट कमेटी हो जो कि एडवर्टाइजमेंट को वेट करे कि which is really kind of good enough to be allotted this space. यानी हर एक चीज को लिए जो 2 लाख दे दे उसको देने में उसमें कंटेंट है क्या है, are they really eligible to be partners? तो वो जब आप लोग खुद ही डिसाइड कर लें, जो भी कमेटी है साइंटिफिक, और उसके बाद फिर ये दिस इज एक सजेशन फ्रॉम माय साइड, तो एक एसओपी बना के उसको फॉलो.
So we can have a content evaluation committee who can vet the actual content which is to be right. So any other suggestions?
I mean, हम लोग अभी तक whatever activities we've been doing, it's free of cost. Now maybe it's time that we should start doing the workshops and seminars, and then we fees हम देना शुरू कर दें. So that is going to be a kind of generation of the funds. Other societies do that.
And we have discussed those options. The observation of the president was that in all those cases in which you have to collect that amount individually from a number of people, there is more effort, there is less return as compared to en bloc generation of funds in this form.
But more than that, we have to have multiple sources.
जी सर, वो मैं नेक्स्ट पॉइंट पे बताता हूँ. सर
use the approach of finding donors, like people like who can donate some funds. उसकी अगर हम donor ढूंढें यूनिवर्सिटी लेवल पे या और दूसरे लेवल पे अगर donors मिल जाए. और दूसरा आइडिया ये था कि अगर आप वर्कशॉप्स हैं या इस तरह की जिसमें people are interested, like जो बहुत general हो, grant writing हो गई या इस तरह की ऐसी जो कि usually people are interested, bioinformatics है तो उसकी कुछ इस तरह की जिसमें लोग ज़्यादा इंटरेस्टेड होते हैं. उसमें ये है कि अगर आप ऑनलाइन कर लें मगर आप थोड़ी सी उसकी कुछ फी रख लें तो आपके वो वाले एक्सपेंसेस भी थोड़े से हो जाएंगे.
I'm the information secretary for Pakistan Chess Society also. We are having our annual conference which is about 8,000-9,000 participants. No shields, no certificates, no gala dinner, nothing, purely scientific. आप जितनी बाहर की अटेंड करते हैं कॉन्फ्रेंसेस, I will remain a speaker as an international speaker at ERS, याकी वगैरह कुछ भी नहीं. आपका नाम अनाउंस होता है, you go stand on stage, अपनी बात की वापस आ गए. बहुत हुआ, बाद में पोस्ट में आपको एक PDF आ जाता है कि जी you presented.
So actually the shields which I mentioned are the lifetime membership shields, and they are the only token of association which we are giving out at the moment. So even if we dispense away with those, then practically there's no other such.
Why not a certificate which someone can frame on their wall? So ये सोच में आप. और दूसरा, I would tend to disagree with what the president साहब कि जी पैसे कलेक्ट करना एक मुश्किल काम है. आजकल के ज़माने में बिल्कुल मुश्किल नहीं है. आप easy पैसा से लोग वर्कशॉप की फीस देते हैं.
It's not difficult, but it has diminishing returns in the sense that more effort is required to raise the same amount of money. It's obviously not difficult.
Suppose we are doing a workshop on allergy testing. हमारी workshops डॉक्टर सुबिया गवाएं हमेशा jam packed full होती हैं. आप 5 या 10,000 उसकी फीस करें, 20 participants हों, you're getting 200,000 rupees, which is more than any of your sponsors.
But will people pay 5 to 10,000 for that workshop? I'm not aware of.
People pay 100,000 for those workshops.
Right.
ठीक है, so
all of these.
जिसने आगे उससे commercial पैसे कमाने हैं, उसके लिए तो बात ही कोई नहीं, because वो 100,000 वो 15 दिन में वापस कमा लेंगे. इसी तरह HLA typing और बाकी सारी, these are very high value commercial ventures which should be explored. Just my suggestions.
I'll consolidate all these options, all these suggestions, and we'll present as part of the minutes later on. So one of the steps that we have worked on is the association of PSI with Pakistan Science Foundation. We took a leaf out of another society's book recently who registered with PSF and were given a grant of 500,000 rupees immediately at the association. We have done the necessary paperwork and we are working on it. We have talked with them. They have said that it's part of their mandate to finance those societies who can demonstrate that they have been in active existence over the past few years and they have been meeting regularly. So all the check boxes which are required can be ticked easily in our case. So this is one step which we are going to take. And they provide financial assistance at the outset as well as once the society is registered with PSF, they provide travel bursaries for people who are going abroad for presenting papers and other such things. So this is one thing which we are pursuing, and we will follow it up with the progress and give feedback to you regarding the progress. Now this is.
Can I just add?
Sir.
Pakistan Science Foundation के अलावा Pakistan Academy of Sciences भी है. They have a very similar mandate और उनके जो fellows हैं, they only select the so-called leading 100 scientists of Pakistan. उसमें Professor Rabia Sahiba is there, she's on that. Rumina is there, I'm there. I think we have maybe one other person. So that can be put forward as well. और उनको पैसे funding आती है Comstack वगैरह की भी.
Right.
So these are things that we can explore.
Now, another important step which we have been looking at is the initiation of a journal of Pakistan Society for Immunology. The society has been around quite some time, has been meeting frequently. I also had the privilege of working as an assistant editor on the PAP's journal, which is the Pakistan Journal for Pathology. So we had some background meetings before coming here, and it appears that it's not very difficult with the kind of active participation we have. It's not difficult to aim for a biannual journal at the start, in which we will need to pitch 6 articles per issue and ask for PMDC evaluation at 1 year. The website maintenance for the journal will be mandatory, and we will need to set up an OJS management system. Again, the problem here is the expenses. The initial expenses will include the initial domain name and hosting on the .com domain and the print ISSN, which comes to about 125,000. And the annual recurring expenses for keeping the journal afloat, other than the strong peer review process, will be the website, the OJS, the online submission system, which is now mandatory by PMDC as well as HEC for all journals. The Crossref or the DOI, which is essential to list your articles internationally. Then the OJS manager, somebody who can do it. We have already shortlisted that person. So we have done some things on the list. And the online ISSN eventually, which allows the listing on Scopus and later on PubMed. So all of these are contingent upon the first point, which is that adequate fundraising should be in place, fundraising mechanism should be in place to do this. So I would request the House about their opinion and patronage, obviously, for the concept, or whether they agree or not that we should have a journal.
So ultimately, हमने होना ही था journal को. So as soon as we have the enough funding, I think this is a very good idea. और फिर उसके तरह हम अपने कुछ international editors और reviewers
जी वो
उनको हम उस पर डालेंगे ताकि उसकी work भी.
I have prepared a separate document. I'll float it separately to all the members, in which I have listed the necessary steps. I have not listed those steps in which we don't foresee a problem. The stumbling block remains the financial issue. The rest, we have reasonably senior and very competent scientists at all levels, and physicians and pathologists. So हमें editorial board को set up करने में we can request their patronage, and we believe that we can get it done. लेकिन issue यही होगा financing वाला.
अगर एक तो ये जो भी इन कॉन्सेप्ट आप मैं सजेस्ट करूँगा कि जो भी चीज़ करना चाहते हैं ये सारी बहुत एसेंशियल है, बहुत अच्छी सजेशंस हैं, और इसको अपनी यहाँ से जैसे काइंड ऑफ सपोर्ट हो जाती है, उसके बाद ये जो आपकी एग्जेक्टिव है ना, उसमें डिस्कस करके उसको डॉक्यूमेंट करके अप्रूव कराएं और एक पायलट इस पर रन करके देखें कि आपको कितना कोई इसमें गैप रह जाता है. ये जो आप मसलन जो एडवर्टाइजमेंट्स हैं कवर की साइट कवर फर्स्ट पेज या जो भी तो क्या गैप रह जाता है, और ये साल भर कहना 6 इश्यूज का.
सर ये इनिशियली बाय एनुअल हम करेंगे इन 2 इश्यूज, और चूँकि ऑनलाइन है फिलहाल प्रिंट एडिशन नहीं होगा, ऑनलाइन होगा. तो वो 2 इश्यूज हो या क्वार्टरली हो वो इमटेरियल है। 2 इश्यूज भी हम इसलिए कह रहे हैं ताकि जो इनिशियल इनटेक है आर्टिकल्स की शुरू में कम होती है, इसलिए हम बाय एनुअल टारगेट कर रहे हैं। जो पैप का जर्नल है वो क्वार्टरली है, तो लेकिन हम
आपको मिनिमम क्या करना होता है फॉर दैट क्लासिफिकेशन विद
1 year of continuous publication जिसमें 5 ओरिजिनल आर्टिकल्स पर इशू प्लस 1 केस रिपोर्ट एंड द एडिटोरियल बोर्ड उसकी कॉन्स्टिट्यूशन है सर, जो कॉम्पोजिशन रिकमेंडेड है जो एडिटोरियल बोर्ड की पीएमडीसी और एचईसी की, लेकिन वो हमने देखा है कि वी कैन रिक्वेस्ट द सीनियर्स फॉर द पैट्रनेज, वो हो जाएगा। वो ये नहीं उसमें हमें किसी और को भी वी डोंट नीड टू लुक एट समबडी एल्स, तो वो भी हो जाएगा 1 ईयर पे। हम इसमें हमें कुछ किसी लेवल पे हमें तमाम इंस्टीट्यूट से ये कमिटमेंट भी चाहिए होगी कि दे विल सबमिट द आर्टिकल्स इन दैट जर्नल, ताकि वो शुरू में वो जो हमारा वैल्यूएशन पीरियड है उसमें
आप अप्रूव करके और उनसे उसको डॉक्यूमेंट करके शुरू कीजिए, ज़रूर थोड़ा सा प्रोसीड करना पड़ेगा जैसे हर चीज़।
Can I just ask कि pharmaceuticals को इसमें अगर एडवर्टाइज करने की इजाज़त देंगे ना, तो they can, especially allergy के हिसाब से, they can easily bear all these expenses. You see, so if you have 2 people, some suppliers of HLA kits, let them have the priority because they are making the most money out of immunology in Pakistan right now. Have you spoken with anyone like that?
So they are interested in advertising only in print versions, generally speaking. अभी अगेन कमिंग बैक टू द सेम थिंग कि जो पैप का जर्नल है वो एडवर्टाइजमेंट्स लेता है फॉर प्रिंट वर्जन। हम इनिशियली एम कर रहे हैं, वी आर नॉट गोइंग इनटू द प्रिंट साइड, हम इनिशियली ऑनलाइन ISSN DOI वेबसाइट और यही HCC और PMDC की रिक्वायरमेंट्स।
Exactly, if they are willing to pay, they'll pay this and they'll pay for the print, and then you get everything covered. आपको कोई खर्च नहीं पड़ता। और प्रिंट वर्जन में आप कितनी कॉपीज आप प्रिंट कराएंगे? 1500 200 इस तरह भी करें, but if they are willing to pay these costs, I don't foresee that as a problem. 50,000 तो आम एक A4 के ब्लैक एंड व्हाइट ऐड कर देते हैं, लाख रुपए वो कलर ऐड कर देते हैं जी। इस तरह की आप
ऐसे लीजिएगा नहीं, आई थिंक बिल्कुल आप सही कह रहे हैं, क्योंकि पैप के जर्नल में भी PJP में भी जो पूरे साल की जर्नल पब्लिकेशन कॉस्ट है फॉर 800 टोटल कॉपीज, वो इज नॉट मोर देन 150,000, और उसके अगेंस्ट जो टैरिफ्स हैं, मतलब जो एडवर्टाइजमेंट टैरिफ्स हैं, वो बिल्कुल इसी तरह ही है कि वो अगर 4 क्वार्टरली जर्नल है, अगर 4 जर्नल्स में 1 A4 साइज 1 साइडेड कलर करते हैं तो इट इज़ 150,000, तो बिल्कुल ठीक है। इसको भी हम प्रिंट वाले ऑप्शन।
मेरा एक सवाल था कि आप जर्नल अगर शुरू करते हैं तो मेरी आवाज़ इतनी बड़ी है, अगर आप जर्नल जैसे आप शुरू करना चाहते हैं तो इसमें जो यंग साइंटिस्ट हैं या जो स्टूडेंट्स हैं वो they are unlikely to submit for publication, क्योंकि मतलब will end up with primarily with review articles होगा ये भी सोचने वाली बात है, क्योंकि देखें जब जो स्टूडेंट्स है उसको अपना FCPS का पेपर छपवाना है, उसको PhD कर रहे हैं कुछ है, वो पाकिस्तान इस मतलब जर्नल ऑफ पाकिस्तान सोसाइटी फॉर इम्यूनोलॉजी में पब्लिश करेंगे नहीं करेंगे, ये भी सब सोचने की बात है कि जो आपके फर्स्ट 2 इयर्स हैं उसमें ओरिजिनल आर्टिकल्स अगर आप शुरू करते हैं तो सबमिशन बहुत मुश्किल होगी। तो ये अगर आपका एडिटोरियल बोर्ड जो है वो इस पे तैयार हो कि वो इस चीज़ को देखेंगे एंड दे विल गेट आर्टिकल्स फॉर पब्लिकेशन, फिर तो ये चीज़ प्रैक्टिकल है करना, क्योंकि SIOT ने भी ये किया था, कोशिश की थी, मगर हुआ ये कि ओरिजिनल आर्टिकल जब कोई नहीं भेजता था, दे ऑल वांट उन जर्नल्स में जो एस्टैब्लिश्ड हैं, तो बहुत मुश्किल हुई थी रिव्यू आर्टिकल्स।
रिव्यू आर्टिकल्स में काउंट नहीं होते टुवर्ड्स PMDC वैल्यूएशन, तो इसमें बिल्कुल आपने सही कहा कि वी नीड टू हैव अ मैकेनिज्म वेयर वी हैव एटलीस्ट सम काइंड ऑफ कमिटमेंट फ्रॉम ऑल द स्टेक होल्डर्स फॉर एटलीस्ट 2 इयर्स, क्योंकि पहली वैल्यूएशन 1 ईयर पे है। एट FIP वी आर विलिंग टू मेक दैट कमिटमेंट कि जी हम हर इशू में एक आर्टिकल कंट्रीब्यूट करने को, ऑब्वियसली उसमें आप बहुत हाई यानी बहुत आप यानी मे बी फ्रीक्वेंसी स्टडीज, लेकिन इनिशियली टाइप ऑफ स्टडी तो मैटर नहीं कर रही इवैल्यूएशन में। ये मैटर कर रहा है कि कंटिन्यूटी ऑफ प्रिंटिंग हो, 5 ओरिजिनल आर्टिकल्स हो, बीएसएमएलटी के स्टूडेंट्स होते हैं, मल्टीपल फ्रीक्वेंसी स्टडीज एफसीपीएस के लेवल पे भी, डेटा रेट्रोस्पेक्टिव डेटा, क्योंकि हर जर्नल दे गो थ्रू द सेम प्रोसेस। मतलब देखिए कोई ऐसा जर्नल नहीं है जो इवैल्यूएशन पीरियड ना गुजारता, शॉर्ट ऑफ दिस के जो बहुत बड़े इंस्टीट्यूट्स हो। सो वी हैव टू बी रियलिस्टिक, वी उसके बगैर तो नहीं हो सकता।
हमारे जो यंगर बैठे हुए हैं इम्यूनोलॉजिस्ट, आप लोग बताएं ना, हाउ डू यू थिंक अबाउट दिस?
नहीं आप बिल्कुल सही कह रहे हैं मैडम जी की जो बात है उसमें भी बदलना चाहिए। लेकिन मैं अगर यूएचएस की बात करूं तो उन्होंने एमफिल और पीएचडी की डिग्रीज को देने के लिए एक शर्त रखी हुई है, एक सर्टेन कैटेगरी जो एचईसी करती है उसमें जाएगा तब आप लोग। लेकिन हैविंग सेड इट, जो आप कह रहे हैं कि एक इनिशियल पीरियड तो गुजारना पड़ता है हर जर्नल को, उसमें आप देख लीजिए, वर्कआउट कर लीजिए कि उसको कैसे आप कंटिन्यू करें, उसको कैसे करेंगे।
ये मेडिकल स्टूडेंट्स
जो
प्लान
कर रहे हो ना उसमें डालना
अच्छा, जो मेडिकल स्टूडेंट्स होते हैं ये भी, इनको भी मेरे पास से कहा गया है कि आप लोग कुछ स्टडीज करें और वो वर्क कर रहे होते हैं। जो हमारे वक्त कुछ ऐसा नहीं था, वो एक क्राइटेरिया है, नेसेसरी हो गया।
अच्छा मैं थोड़ा सा एक चीज थोड़ी सी एक्सप्लेन कर दूं। पहले पीएमडीसी के जर्नल्स की कैटेगरी 4 होती थी, डब्ल्यू एक्स वाई एंड जी। जी उन्होंने खत्म कर दी है, एक्स वो होती है जिसमें फॉरेन हर आर्टिकल पे फॉरेन पीयर रिव्यूअर हो, जो पाकिस्तान का कोई जर्नल एक्स कैटेगरी में परमानेंटली लिस्टेड नहीं है, वो आते हैं और फिर निकल जाते हैं, बिकॉज इट्स वेरी डिफिकल्ट टू इंश्योर फॉरेन पीयर रिव्यू फॉर एवरी आर्टिकल। अब जो लिस्टेड है वो या डब्ल्यू में है या वाई में है, वाई जो है वो एक्सेप्टेबल है फॉर एफसीपीएस एंड फॉर अदर थिंग्स एज वेल। अब यानी प्रैक्टिकली होना क्या है, होना ये है कि हमने टारगेट करना है कि हम 1 ईयर की इवैल्यूएशन पे इनिशियली हमारी कोई लिस्टिंग नहीं होगी और हम 10 आर्टिकल्स हमने फिगर आउट करने 1 साल के अंदर कि हम पब्लिश कर सकें। और जब 2 इश्यूज आ जाएंगे बाय एनुअल इश्यूज, तो हम इवैल्यूएशन में जाएंगे पीएमडीसी के साथ। और वो जो चेक लिस्ट है पीएमडीसी इस मामले में बड़ी यानी अपफ्रंट है, इफ यू फुलफिल द रिक्वायरमेंट्स दे जस्ट गिव यू दैट प्रोविजनल वाई लिस्टिंग। तो हम एम ये कर रहे हैं कि जिस तरह आपने भी कहा कि अगर हमने ये करना है तो हमें इसको बड़ा रोबस्टली करना है, हम इसको मतलब हाफ हार्टेडली नहीं कर सकते। हम डिले जरूर कर सकते हैं कि चलें अभी नहीं करते, अगले साल से स्टार्ट करते हैं, लेकिन वंस वी स्टार्ट तो सब इंस्टीट्यूट्स जूनियर्स एज वेल एज सीनियर्स, फिर जिस तरह मैडम आपने कहा कि हमारे यहाँ जिस तरह बीएसएमएलटी की क्लासेस हैं उसमें दे हैव टू राइट थीसिस, एक अंडर ग्रेजुएट लेवल वाला थीसिस जो लोकली वो उनका पीजीएमआई में सबमिट होता है, तो हम उसमें से कुछ को थोड़ा सा इम्प्रूव करके एज अ frequency studies publish करवा सके, लेकिन similar commitments will be required from all the stakeholders.
आप अभी कमिटमेंट ले लेना, जो मेंबर्स हैं उनसे आप कमिटमेंट ले लें कि वो एटलीस्ट अपने पेपर्स फर्स्ट उसमें कराएं। तो अगर जो हमारे पीएसआई के मेंबर्स हैं, आपने भी दिखाया कि इतने सारे हैं, तो उनमें से कोई तो कमिटमेंट ले लेना कि हाँ पहला जो इशू होगा उसमें आई विल सबमिट माय पेपर। ठीक है, अगर मेरे स्टूडेंट का प्राइमरी पेपर मैं चाहूंगी कि वो किसी अच्छे में जाए, तो कोई सेकेंडरी पेपर हो सकता है, कोई सेकेंडरी एनालिसिस हो सकती है, तो वो आप इस तरह से ले लें, कोई ईमेल आ जाए और हमसे कमिटमेंट ले लें एंड वी आर हैप्पी टू सबमिट।
दूसरा एक ये चीज होती है कि हर साल पैप में सर फ्री पेपर्स होते हैं, दैट इज अ लॉट ऑफ डेटा। तो हम उन जो जूनियर हैं, जो टेक्नोलॉजिस्ट हैं, उन्हें इनकरेज कर सकते हैं, दे कैन कम अप एंड राइट पेपर। आई मीन उसमें दैट वुड बी सफिशिएंट,
मतलब हम उनको गाइड कर सकते हैं कि उन्होंने सही से लिखा हुआ है कि इसको
जैसे उनकी रिक्वायरमेंट भी होती है, एफसीपीएस और पीएचडी वाले की जो रिक्वायरमेंट होती है।
जी बिल्कुल बिल्कुल आई एग्री।
नहीं सर, जो रिवर्स होंगे वो तो गाइड कर सकेंगे ना।
इसमें मैडम यही है कि पहले 2 इश्यूज के लिए हमें सैक्रिफाइस करना पड़ता है। जो भी अपने मतलब इंस्टीट्यूट अपना जर्नल लॉन्च करता है, दे हैव टू सबमिट ओरिजिनल पेपर्स, और वो जाहिर है क्योंकि अगर प्रमोशन के लिए किसी ने यूज़ करना है या फिर डिग्री के लिए, तो दैन वो क्योंकि एक्सेप्टेबल नहीं होता, तो इस लिहाज से हमें थोड़ा सा पहले प्लान करके ये हमें खुद देने पड़ेंगे, तभी जाके हमारा जो है, क्योंकि जनरल जो पब्लिक है वो तभी सबमिट कराते हैं जब हमारा ऑलरेडी रिकॉग्नाइज हो जाता है। तो या तो फिर हम कोई ऐसा प्लान करें कि किसी को अटैक करने के लिए, जिस तरह ये ट्रैवल ग्रांट लिंक कर दें हम, मीटिंग जिस तरह हमारी होती है, कोई चीज़ का फुल पेपर वो सबमिट करेंगे जो ओरिजिनल हमारे जर्नल के अंदर, उनको हम ट्रैवल ग्रांट देंगे मीटिंग के लिए, यहाँ पे कॉन्फ्रेंस के लिए, एक वे या बट ये है कि एटलीस्ट 2 इयर्स तक हमें ये लाजमी करना पड़ेगा, तभी हमारा जर्नल आएगा।
मेरा सिर्फ ये पॉइंट आउट करने का मकसद ये था कि आपकी बहुत सारी मेहनत होगी ना, ऑब्वियसली यू बीन वर्किंग ऑन इट, so what you have to do is get commitment from other people also, you know, discuss this a little more and get others involved.
काश तो यहाँ पे मैं भी बता, 2 वो बैठे हैं पेपर, तो उनकी तरफ से आ जाएंगे 2 ये 4 5 6
मुझे
नहीं
मैं
7 तक नहीं,
मेंबर से
ये
कमिटमेंट ले
इनकी
लिया।
कमिटमेंट मुझे पता है कि ये तो
हाँ बिल्कुल करेंगे हम, तो खुद आपको अगर आप लेंगे तो हम
तो 3 और चाहिए ना।
इसका इंचार्ज तो नजिया को बनाना चाहिए, सबसे ज्यादा ये प्रोपोनेंट हो रही है, तो मेरे साथ आप काफी
जिनका मैंने कहा है ना, मैं निकलवा
if you are willing to be part of that, you should team up with the team.
मैं मेल से इस पे हम मज़ीद
I will
करेंगे।
definitely talk to मगर as a part of the committee, मतलब मैं आपकी जो member तो हूँ ना, मैं आपकी तो ज़ाहिर है मैं I will, अगर आप मुझसे कहेंगे मैं I will definitely submit something।
मैम जनरल के लिए हम सेपरेट कमेटी भी कॉन्स्टिट्यूट करेंगे जो फिर अपनी मीटिंग्स भी करके
ठीक है आप
सर हम भी एफएक्पी से 2 आर्टिकल वी कैन कमिट
8 तक हो गए हैं सब जगह
कर देंगे
दो सर
भाई आ गए तो 9 भी हो जाएंगे,
कर देंगे कोई मसला नहीं है।
कमिंग ईयर में सब मेरे 6 आ रहे हैं।
the next point pertains
Okay, so
ज़्यादा ही हो रहा है हमारे पास
यहाँ
otherwise।
we have discussed it.
चलो ये तो हो गया, पैसों का बंदोबस्त वो भी
so उस पे भी hopefully हम will make some progress, हम इस पे कर रहे हैं सर ऑलरेडी। CPSP curriculum development की कुछ activities हुई थी। I just wanted the house to know a series of 4 meetings were organized on Zoom by Brigadier Tahir between April and June, and 3 teams were nominated and headed by following members. The team to develop accreditation documents, department accreditation department. Then there was a team which developed the workplace-based assessment for immunology exams, and the team worked on POS and curriculum. Some progress has been made on it, and this is an ongoing activity. कुछ इसमें चीजें तैयार हो के सबमिट हुई।
वो तो सबमिट कर दिया था ना, जब भी दिया वो उनके पास से क्या
IUIS representation. One delegate is extended an invitation by IUIS to represent PSI at their annual congress every year. Currently, the delegates go to IUIS Congress on own expenses. The proposal is that we should have a committee to invite applications from members who want to participate and devise modalities to select delegate from those applicants, and then fully or partially finance their visit under the banner of PSI officially.
अदरवाइज में 3 लोगों को मिला जा रहा है। मेरा पोस्टर्स एक्सेप्ट हुआ था, बट आई एम नॉट गोइंग बिकॉज़ आई डिड नॉट गेट द ट्रैवल पर्सन। तरजुमी को तो ट्रैवल पर्सन और मुझे आज पता चला कि हमारा को भी ट्रैवल पर्सन मिल गया।
किसको भी है?
तरजुमी फुल फंड,
अगर फुल फंडेड और पावर
नहीं पता चला, और ये भी जाएगी इंशाल्लाह अगर तो वीज़ा हो गया।
एक्चुअली दोनों चीजें हैं ना, एक तो जिन्होंने सबमिट किया है, लेकिन वहाँ डेलीगेट की अटेंडेंस एज पार्ट ऑफ द एनुअल कांग्रेस, इवन जो जिसने नहीं भी सबमिट किया एब्स्ट्रैक्ट, वो डेलीगेट तो फिर भी इनवाइटेड है। तो हम बहुत एक्टिवली उस तरह एंगेज नहीं कर रहे IUIS के साथ, तो उसको हम फॉर्मलाइज करना चाह रहे थे कि लोग तो मल्टीपल भी अप्लाई करते रहेंगे, खुद सबमिट करते रहेंगे
एब्स्ट्रैक्ट। मैं सिर्फ उसको कर रही हूँ, तुमने कहा 1 डेलीगेट या 3 एक्चुअली जो जाएंगे हमारे पास। जी सर,
तो एक को आप कुछ ना मिले तो डेजिग्नेट कर देते हैं, आप को कर देंगे ये दिन का
जी।
So ये जो है full or partial financing the visit, इसके लिए फिर आपको कोई you have to come up with a
अभी तो हमें पुराने पैसे नहीं मिले, अभी तो फालतू की बात है।
तो यही है जैसे ताहिर भाई कह रहे हैं, जो जा रहे हैं उनको डेजिग्नेट कर दिया जाए।
जी, प्रीवियसली भी ऐसे ही हुआ है, जब मैडम भी नहीं थी तब भी।
मैं तो मैं गई उस वजह
Finally, a monthly educational activity as CPSP has been planned. Schedule has been finalized in liaison with all the institutes, and it will be held once a month. The activity will be for 2 to 3 hours. It will be a monthly activity, and डिफरेंट इंस्टीट्यूट्स मतलब एक दिन होगा पर मंथ जिसमें अब एक रेगुलर शेड्यूल के मुताबिक इम्यूनोलॉजी
First Friday of every month it is going to be held in CPS. ये एजुकेशन एक्टिविटी ऑलरेडी चल रही थी और इम्यूनोलॉजी को वो कहते थे कि जब जिस दिन भी 5th सैटरडे आएगा जिस मंथ में 5 सैटरडे होंगे तो हमें ऑल्टरनेटली हमें और माइक्रोबायोलॉजी मिलते थे, तो हम तो भूल ही जाते थे पर वो एक हफ्ते पहले हमें कहते थे कि आपने अरेंज करना है। फिर अब हमने ये किया कि हमें एक दिन दे दें, हमें पता होगा कि रेगुलरली हमें करना है और हमने सब कोऑर्डिनेटर्स बना दिए हर इंस्टीट्यूट से, जैसे SIT से डॉक्टर बढ़िया कोऑर्डिनेटर हैं, तो जिन्होंने हमने नोट किया था जिन्होंने हमारा नाम ले दिया हमने उनका कैलेंडर बना दिया, 6-7 मंथ का कैलेंडर हमारा चला गया।
There are any other items of interest? This is going to be followed by the Finance Secretary's report.
Thank you very much.
सेशन चेयर कर दी छोड़कर
जैसे कि मैं बता चुकी वी एक्चुअली डू नॉट हैव फंड्स, 2 लाख रुपीस इज नथिंग, अगर जो पेमेंट बची हुई वो देंगे तो वी हैव लेफ्ट इन नथिंग प्रैक्टिकली, एंड he's given very good suggestions. I had a few suggestions. एक तो ये कि the time we started जो हमने membership fees रखी थी that's very minimal, जो हमारी associate की है that's rupees 700, we need to revise that at least minimum of 2 or 3,000, and I think किसी को इतनी वो नहीं पड़ेगी, so we need to revise the membership dues. दूसरा, the members like when we started it's a very slowly growing society, और ये slowly रहेगी because we have very few immunology residents coming up. We need to spread our wings, और जो हम cater कर सकते हैं nephrologists को कर सकते हैं and pediatricians को कर सकते हैं, so if we could get new members there, and secondly जब हम journal शुरू कर रहे हैं तो उनके लिए भी easy access भी हो जाएगा, तो we need to do that. And
lifetime members का भी डाले कि annual subscription होनी चाहिए,
and subscription होनी चाहिए because once paid and then there's no getting back to them. एक रेगुलर ये होना चाहिए कि आपकी अमाउंट आती रहे, एंड स्टार्टिंग विद 700 इज वेरी मिनिमल। लाइफ टाइम मेंबरशिप आप भी ले सकते हैं, कोई लाइफ टाइम मेंबरशिप की तो कोई नहीं जाएगी ना, जगह खत्म कर देना तो या फिर जो आपके रेगुलर मेंबर्स हैं
उसको रहने देना, डॉक्यूमेंटेड उसका बना रही है तो ये खत्म करना तो कोई अच्छी बात नहीं,
लाइफ टाइम
मेंबरशिप सब्सक्रिप्शन रखने की अभी जरूरत हो सकता है किसी वक्त आप रोक दें जब आपके पास
सर उसका एक वर्केबल अल्टरनेटिव ये है कि हम मेंबरशिप कैटेगरीज वही रखें और गुड स्टैंडिंग फीस रखते हैं क्योंकि मतलब
आपकी ये ना
गुड स्टैंडिंग फी, क्योंकि मेंबर्स भी हमारे स्पेशली जो लाइफ टाइम वाले नहीं हैं वो दे डोंट पे रेगुलरली, तो वी हैव दैट कैटेगरी बिटवीन गुड स्टैंडिंग एंड
गुड स्टैंडिंग वाला लाइफ टाइम वालों की ज़्यादा रखें और
तो we can decide right now the amount क्या रखना चाहते हैं।
जैसे एक सजेशन देते हैं कि जैसे अगर लाइफ टाइम मेंबर हैं हम और तो जैसे ये मीटिंग है या कोई और मीटिंग है उसमें हम कोई थोड़ा सा उनको कोई अलग से उनके कार्ड के ऊपर जैसे रिबन लगा दें या मतलब समथिंग टू डिस्टिंग्विश देम,
we could give them membership cards.
हाँ, anything.
बहुत लोग हैं पूछा कि we have made the payment but we haven't got anything. We are not giving anything to anybody. वो एक अवार्ड होता है लाइफ टाइम मेंबर्स को, बट जो जूनियर्स होते हैं उनके लिए बड़ा
सबको चाहिए होता है
सबको
सर्टिफिकेट
इवन इट्स अ मेंबरशिप कार्ड एंड यू अपग्रेड इट विद एवरी मेंबरशिप, वो तो दैट
तो ये होता है ना कि रेगुलर मेंबरशिप लिए किसी ने और वो 1-2 साल की है तो आप जो सर्टिफिकेट दोगे आप उसको मेंशन कर दोगे यहाँ से यहाँ तक है
वैलिड
और उसके बाद फिर उसके बाद दोबारा अगर करते हैं
so can we decide on the amount right now कि हम जो एसोसिएट हैं वो 700 से कहाँ 1000 2 to 3000 तक ले जाए,
मर्जी मुझे नहीं पता,
2000 से स्टार्ट करते हैं
और 5000 फॉर गुड स्टैंडिंग लाइफ मेंबर्स,
हाँ 5000 पर ईयर
डेली लाइफ मेंबर्स, और जो रेगुलर मेंबर्स हैं उनकी 2000 थी तो वी कैन रेज दैट टू 5000।
नहीं
से जो रेगुलर मेंबर्स होते हैं दे आर नॉट FCPS ट्रेनी और एनीथिंग,
नहीं FCPS 2000 पे ही रखें, और जो गुड स्टैंडिंग मेरा भी ख्याल है लाइफ मेंबरशिप जिनके पास है उनकी गुड स्टैंडिंग जो है वो 5 पे।
So लेकिन we had categories of associate, regular and lifetime.
लेना चाहिए, क्या हो गया
सर मतलब समझ नहीं आ रही जो रेगुलर
समझ आ
मेंबरशिप
गई
नहीं मैं आपसे बता रही हूँ रेगुलर मेंबरशिप जो है तो 2 साल की होती है ना, तो उसके पैसे नहीं बढ़ाने हैं,
उसकी पैसे 2000 से टैक्स कर दो
सर दे थ्री कैटेगरीज, एक तो
Already those
एसोसिएट,
are.
जी सर, एक एसोसिएट है, एक रेगुलर है, एक लाइफ टाइम है। एसोसिएट वो है जो अंडर
प्रोजेक्ट करें ना कुछ भाई यहाँ पे लिखा हुआ
अच्छा,
ना आपने खर्चे प्रोजेक्ट लिए ना आमदनी प्रोजेक्ट लिए। एक तो पहले मुझे एतराज है, फिर उसके बाद ये बातें होती हैं सजेशन वाली, तो वो रिपोर्ट किधर है?
अच्छा एक्चुअली
वो असल में तो वो है, उसके बाद सजेशन आती हैं कि जी अब ये करना। वो मैंने बता तो दिए,
वो सारे हो गए थे तो आई डिडंट
नॉट, लेकिन ना 2 लाख है और आप बताएं कि इस साल ये खर्च हुआ या नहीं हुआ या इतना कर्जा रहे, कुछ तो आना चाहिए ना।
सॉरी हाँ we can do that कि actually I have it लेकिन ये कि we can do that and then we can
उसके बाद लिखा हुआ हो कि ये 4 कैटेगरीज हैं जिनमें अब ये एनुअल सब्सक्रिप्शन है, इसको यहाँ तक बढ़ाने की सजेशन है, इसको अप्रूव कर।
Yeah, we can do that. We can do that.
लिखा हुआ सामने है तो फिर उसी वक्त बात हो जाए, बजाय ये।
So what's the life membership fees now?
Lifetime membership 10,000.
No.
7,000 थी, हम लोग ने 10,000
मैं ऐसे ही पूछ रहा हूँ डॉक्टर तनवीर अंजुम के लिए। परसों मैंने उनकी वेबसाइट खोली और वो सारा आपसे जो बात हुई थी उसके ऊपर 7,000 लिखा है। मैं थोड़ा सोच रहा था कि हमने तो 10,000
10 दिए थे इनिशियली जो स्टार्टिंग मेंबर्स थे, they volunteered कि we'll start with 10. So ये हुआ।
So it's written as 7. So at least that should go, not even 10, it should go higher if it should be lifetime. But at least 15,000 at least होना चाहिए. And as Taibai said, कि we should have a जो उमेर वाली suggestion की certain a good standing fee.
Good standing fee.
It won't affect your membership. मतलब अगर कोई नहीं pay करता, he won't be thrown out of life membership. वो तो हो गया. But that's his contribution to
So
the
it's similar in PAP, like good standing list PAP भी generate करते रहते हैं, the ones who are paying उनकी आती है।
जो लाइफ टाइम मेंबरशिप के जी देते लोग दफा देते हैं, जो रेगुलर मेंबर्स होते हैं वो देते हैं।
उनकी good standing
वो गुड स्टैंडिंग है ना, इसीलिए वही मैं कह रही थी कि गुड स्टैंड जो रेगुलर है वो हमारी 2 साल के लिए 2,000 है। We should now increase that membership, क्योंकि रेगुलर जो होते हैं वो मतलब वही फेलोज हैं, मतलब जो हो चुके हैं।
रेगुलर का भी एनुअल है ना, वो लिख के अगर आप करें ना तो या भिजवा दें बाद में, अगर एनुअल कर दो उसे 2,000 वही चेंज हो जाएगा। इसी तरह लाइफ टाइम को भी एनुअल 5,000 गुड स्टैंडिंग कर, तो ये एनुअल सब्सक्रिप्शन
So send out an email, यही सारी बातें आप
email
में
में
भेजें,
कर देते
and we can bounce it back and forth and decide.
Sure sir, we'll do that.
और उसमें भी टाइमलाइन सेट कर देना। मैं भाई कब तक, when do you want to decide? Within a month?
एक proposal बना के email पे float कर देते हैं, we'll get the feedback.
उसको open end ना रखें, reply by this date so that people know that this फिर
So like reply within 1 week या 2 week and we can finalize it within a month. कि हम और उसके accordingly फिर website पे भी
और ये भी रखना पड़ेगा कि कितनों ने रिन्यू करवाया मेंबरशिप। मैं याद होगा कि लास्ट टाइम मैंने बहुत मेहनत की थी और बहुत सारी मेंबरशिप मैंने रिन्यू करवाई थी, बोथ फ्रॉम द एसोसिएट एंड फ्रॉम द रेगुलर मेंबर्स, कि उनको बार बार ईमेल लिखा था और उन्होंने फिर पैसे पे किए थे। तो ये और सारा मैंने भेज दिया था कि किसने कर दिया किसने नहीं, तो आपको उसका भी ट्रैक रखना पड़ता है और उनको कहना पड़ता है कि भाई आपका, जैसे हमारे पास बाकी सोसाइटीज का
जो आपने दिया था उसी को कंटिन्यू करें।
तो फिर वो शेयर कर लेना how many life members we have, how many regular members we have,
कितनों ने दिया कितनों ने नहीं दिया,
कितने पेंडिंग है बिल्कुल। तो एटलीस्ट उस तरह के अगर आपके वो स्टूडेंट है और उसने नहीं दिया, एटलीस्ट यू कैन पुश देम या एनीवन कैन पुश देम या,
क्योंकि लोगों को याद नहीं रहता, जब आपका ईमेल जाता है ना तो फिर वो उनको पता होता है कि अच्छा ये रह गया है।
Exactly. We need to send regular emails and we need to follow up के
हमारे पास भी तो आते हैं ना जो किसी और हम सोसाइटी के मेंबर होते हैं।
I forgot to pay my car tax this year, मुझे भी याद आया, भूल जाता है बंदा। ऑनलाइन
So thank you very much. This closes this session of an annual general meeting of PSI.
बहुत शुक्रिया, थैंक यू।
डॉक्टर सर एक और
सर एक ग्रुप सेशन करवाइए।
आपका नाम लिखा नहीं मैं थी ना मगर मैं आज हाँ तस्वीर देखने बता देंगे हम नीचे
थोड़ा सा झूठा भी है आप सबसे
एक समिति
या आपको पैकेज
Yes, ma'am. Yes, okay. One more. Thank you, sir.